form that will be put in the chat box at the end of today's session. It is my honor to introduce the moderator for today's session, Dr. Yatin Mehta, who is the chairman of critical care in Medanta Institute Hospital and Institute. He is also the head or chairman of the Infection Control Committee and also the Anti-Microbial Stewardship Committee. He has many hats to wear. And welcome, Dr. Yatin Mehta. Well, today our first speaker of the day is Dr. Esmita Charani. She will be talking on communication and education leading to behavior change. Let me introduce Dr. Charani. Esmita is a research lead practice, research lead for practice design and engineering at the NIHR Health Protection Research Unit for healthcare associated infections and antimicrobial resistance within the faculty of medicine at Imperial College London. She's an honorary associate professor at the University of Cape Town and a visiting researcher at Auckland University Hospital, Bergen, Norway, and also an adjunct faculty to Amrita Institute of Medical Sciences, Kochi, Kerala in India, where she is involved in helping implement and investigate national antibiotic stewardship programs. Her work in AMR has been recognized through the Academy of Medical Sciences, UK, India, AMR Visiting Professor Award. She's an expert advisor to the Commonwealth Pharmacy Association and a Global Health Fellow with the Office of Chief Pharmaceutical Officer, England. She is also involved in mentoring and supporting clinical pharmacists across healthcare settings and economies in implementing stewardship programs. Her doctoral thesis investigated antimicrobial stewardship across India, Norway, France, Burkina Faso, and England. She, after completing her postgraduate training in Cambridge University hospitals and 10 years of experience as a clinical pharmacist, Esmita began her research career. She's an investigator in NIHR Invention for Innovation Award, investigating the development and use of point-of-care personalized clinical decision support tool for antimicrobial prescribing. In her illustrious academic career, the focus of her research has been behavior change interventions in the field of stewardship and the application of social science research methods to develop contextually relevant solutions. She's a co-investigator on the ESRC Award, optimizing antibiotic use along surgical pathways, addressing antimicrobial resistance, and improving clinical outcomes in England, Scotland, Rwanda, India, and South Africa. Esmita completed her master's in pharmacy at University College of London, her MSc in infectious diseases from London School of Hygiene and Tropical Medicine, and her PhD from Imperial College. Wonderful to have Esmita with us. So, Esmita, unmute yourself and start.
Hi, everyone. Thank you so much for that introduction. I'm so sorry it was so long. Thank you, Sharmila. It's a pleasure to be here, and how lovely to have such a strong group of people from across the region. It's really humbling to be speaking to you all, and I hope that everybody is doing well through this pandemic. So I have been tasked to speak about the implementation of in this workshop on implementation of antimicrobial stewardship in resource limited setting on communication and education leading to behaviors change. And I just wanted to start by just highlighting, you know, when we talk about AMR, how we communicate about AMR is still a long way off effective communication means. We keep talking about this threat of antimicrobial resistance, how many people is going to be killing by what date, and how many people are dying each year. And although this is a good way, perhaps for us, a sobering way for us to understand the scale of the risk, we have to understand that our colleagues and healthcare professionals in different contexts and different specialties may not have the same appreciation of the risks, or may have different measures of risk for their patient cohorts and for their own health and well-being. And that's something that I think in the AMR discourse we need to spend more time on, is how we communicate about this issue globally to be able to bring about change and bring everyone on the same page as we are. Of course, talking about these threats is really important when we want to garner interest from funding. So when we look at the funding landscape and research landscape for antimicrobial stewardship and antimicrobial resistance research, particularly in human populations, in optimizing use in human populations, there are still a lot of inequities. The first inequity being around this between the amount of funding available for research and development of new drugs, which of course is essential, is really important, but it has to be measured against the funding available to us to understand how we can optimize the use of existing agents. Because unless we do that, no matter how many new drugs come into the market, we will have the same challenges in getting people to use them appropriately. So when we look at the research landscape and available funding, a lot of it goes into technology development and technology evaluation. But we don't invest enough in better implementation research, in understanding how we can engage with policy makers and stakeholders across the One Health agenda, and in understanding the cultural and contextual drivers for antibiotic use. And these are important factors. And also in surveillance, we have to be able to measure how we are using antibiotics currently, if we have any chance of improving them. So these are the inequities that we face with, as well as the inequity of funding across high income and low and middle income settings. And the examples I'm going to use today really go back to the work that we've been doing in the UK, but also collaborating with colleagues across low and middle income settings in order to be able to develop better interventions that are sustainable for antimicrobial stewardship in hospital settings. Now, when we think about this, it's really important to always remember the patient. What are the factors that drive antibiotic use and infection in hospital settings? Patient factors are really important. The hospital environment and all the invasive devices and techniques that we are using increasingly to keep patients alive and well for longer mean that there are also mechanisms and opportunities for transmission and spread of infection. In addition to this, the hospital environment itself is a huge factor in the spread of infections and the spread of and emergence of antimicrobial resistance. And this is why infection prevention and control has to be an integral part of antimicrobial stewardship, and also in the communication and the education we provide around antimicrobial stewardship. In addition to this, and this is where my interest is and the focus of our research, is all the different people involved in antimicrobial stewardship. You know, it's not just about doctors. We have nurses, pharmacists, visiting specialists, microbiologists. There's a whole host of different people, an army of people and personnel who are involved in patient care and who will influence outcomes. And in addition to this, we have all the support structures and teams that are involved in delivery of healthcare in hospital settings. This includes anthropologists, researchers, health psychologists, policymakers, epidemiologists, statisticians, and increasingly ethicists is really important, because we need to understand the not only do we need research and ethic approval to do our work and research, but we also need to understand the ethical implications of the research that we do, the audience it is intended for, and how it is going to be effective in that audience. So increasingly, we need to consider these factors more effectively if we want to have the best outcome for the patients and their carers, which ultimately is our goal. So how we communicate about the risk of AMR, how we communicate about the benefits of optimizing antibiotic use differ across all of these groups. And we need to understand these differences, and we need to be able to accommodate these differences if we are going to have sustainable change in behaviors. I use this slide a lot. This is a courtesy of Professor Peter Childs, who is, holds the Dyson Chair of Engineering at Imperial, and we are working with him on lots of projects. And, you know, working with people from different disciplines is fantastic because it opens our eyes to the limitations of how we do our work. So he always uses this is a design concept slide. And if you look at healthcare, often we're stuck in the research, in the fuzzy research area, for which we have very limited funding, which we have to stretch, not only to do the research, but to develop a concept and test it to develop a seamless design. And this is where we fail often in healthcare. When we develop our interventions, we're stuck in the research phase. And then we try to develop an intervention very quickly based on the research, not going through this process to develop something that is actually going to work for the people that it is intended to target. So as an example of that, if we look at the existing medication charts that are in use in different parts of the world, and for me, these are all examples of innovation in their own setting. The first one is a medication chart that was in use when I was in Uganda a couple of years ago for research, because printing paper is very expensive in Uganda. So what happens is that clinicians have to make makeshift in hospitals where there isn't a paper prescription. They have to make a makeshift prescription chart using exercise books. And although this is a fantastic innovation, it comes with challenges, particularly around being legibility, around patient safety, around knowing what medicines are to be given in what routes, and for nurses to be able to administer them safely. But also from a surveillance perspective, how on earth could we collect data on the quality of antibiotic use if this is the level of resources we have to do for medication charts? So there are challenges in this. The second photograph is an example of innovation from Amrita Hospital, where I've had the privilege to be working with colleagues for the last 5 years, going back to my PhD days, where they identified that the antibiotic prescriptions were getting lost amid all the myriad of different loose paper records. So they created a very simple innovation of a yellow border around the antibiotic chart, which made it more easily for nurses to be able to find it and give antibiotics in a timely manner, and also separated antibiotics from other prescriptions, recognizing the importance of these particular class of drugs. The third photograph is from University of Cape Town, where the hospital, the Groote Hospital there, where we are collaborating with colleagues, where they have developed a bespoke medication chart, which includes all the elements of optimized antibiotic prescribing in humans into one paper chart. And they have demonstrated through research that this has improved the quality of prescribing and safety of antibiotic prescribing in that hospital. And lastly, in the hospital where I work, we have Cerner, which is electronic prescribing system. And I was very lucky when I was collecting data for my research. I followed the transition from paper to electronic prescribing systems in our hospital. And I thought it would solve a lot of our issues around the prescribing errors and the difficulties in communication between teams. But what I identified, actually, even though I wasn't looking for this in the research I was doing, was how much using a computer prescribing system affected the communication across teams. These, we call them computer on wheels. So we have these computers on wheels which have the server on them, and clinicians and all healthcare professionals access all patient data and medical notes and medication chart on these computer on wheels. And what it has done, it has pushed people into silos, because the prescription view for the nurse and the pharmacist and the doctor are completely different. So although we're using the same system, we're working on different pages. And this creates complications around communication. A second point about communication and using electronic prescribing I identified was that before, when we had paper prescribing, everybody would congregate around the patient bedside. Somebody would go and retrieve the patient prescription chart, and they would go through it together with the patient and discuss it. Once we had the computer on wheels, the whole of the ward round sort of migrated to the computer, and the patient became a satellite, or almost an outlier to the conversation, and they were often left out of the conversation. So this is why it's so important when we develop innovations in healthcare, is to understand the context in which we are implementing this innovation and the implications this will have for behaviors of teams and individuals. Before we had the electronic prescribing system, we worked with the Cabinet Office here in the UK, the Behavioral Insights team, to develop a bespoke medication chart to influence, redesigning the choice architecture. And we described improvement in prescribing. However, now we're working with Professor Peter Childs specifically to look at across all the existing technologies and innovation around prescribing to identify what an ideal prescription system looks like, and how could we develop a system that is of best use to clinicians, because often when we develop these innovations, we don't bring in the input of clinicians. So the wider interventions, what I've just described, also applies to the wider interventions we have in a hospital setting around antibiotic use and infection prevention and control. This is just some of the examples of interventions we have in place in blue in the hospital where I work, against in black some of the national policy and guidelines that have come out over time, and in red the international directives, guidelines and policies that have emerged around infection control and antibiotic use. And as you can see, it's a very cluttered, it's a very noisy space in which we're trying to change people's behaviors. And what we tend to do often then is it's a means driven. We try to see where we have resources and what can be done quickly, and that's what we do because that's all we can afford to do. So what happens is we talk about low hanging fruit is often we just target junior doctors because we have most access to them, and we provide some limited educational opportunities. What we need to do is overhaul this whole process and understand where there are sustainable gains to be made and how we can develop mechanisms to embed the education and training and the interventions into routine practice and into the context of the environments in which we want people to change their behaviors around antibiotic stewardship. About 10 years ago, we conducted a systematic review, a Cochrane systematic review of all the interventions that were reported in hospital settings for antibiotics stewardship. And we described the differences between persuasive and between restrictive interventions. So restrictive interventions are like stopping people doing what we don't want them to do. So giving them a policy, removing choices from them, policing their behavior. And we found that interventions that were restrictive were effective in the short term, but they were not sustainable. People would default back to their own behaviors or their learned behaviors and their practices. Persuasive interventions were more sustainable, but were more difficult to implement. Persuasive interventions are things like providing education and training, developing tools that fit to the context. And these are more difficult to implement. So what we do default is we always end up going back to the restrictive interventions. And this is really interesting because Daniel Kahneman, who is a Nobel laureate, has written a book about fast versus slow thinking, and really what persuasive and restrictive interventions and behavior change fits into this way of thinking, which we need to tap into more. And understand that decisions are not emotional, but they're rational. But what we need to do is understand how our peers and colleagues are rationalizing their decision-making around antibiotics and infection control, and to work with that understanding rather than set our expectations for how they should behave without understanding the factors that they consider. So fast thinking, for example, is quick decisions, is easy decisions to make, is leverages on experience and memory. So this is the expert decisions, and this is what restrictive interventions try to influence by removing options from people. But slow thinking is the more difficult, deliberative decisions, which requires more effort, which is when we expect people to rationalize their prescribing, to think about the consequences of their prescribing to the wider population, to the impact of antimicrobial resistance. And for that, we need more effort, but also different approaches, including social science approaches to research. So why take a social science approach to research, particularly around antibiotic use and including education and communication? The reason for this is taking a social science lens helps us define the problem. It provides a context and it leads to more theory-driven systematic approaches. It helps us investigate the implementation and sustainability of interventions in the long term and creates empirical evidence for us to work with. And this is really important because when we look at the core elements of antibiotic stewardship in different settings, we identified leadership to be a core element. And for that, we need to understand the context. We need to understand who is leading in what context and how can we tap into the existing leadership, existing hierarchies and existing social norms in order to be able to affect change. How do we do it, and how does qualitative and quantitative research approaches sort of come together is really important, because often when we take this concept to healthcare professionals, they become defensive and they think that quantitative is the only way. I gave a talk the other week and it was fascinating. One of the, I was chairing a session, and one of the colleagues, one of the audience put in the chat, statistics is a call to action, is an arms to action, and that is all we need. And I completely disagree with that, because if statistics were on its own a call to action, why haven't we acted on vaccine hesitancy? Why haven't we acted on all the health inequities that exist in this world? So it isn't as simple as that. And what qualitative research does, it allows us to understand the helps us define the context. It helps us develop more sustainable strategies that are co-designed with stakeholders. It supports the implementation and evaluation process. So it works together with quantitative research. They are not against each other. And it helps us generate new theories and hypotheses which can be tested quantitatively. And I always use this example. When I came to India for my PhD, I was collecting qualitative data on the implementation of antibiotic stewardship, and then we went back to do ethnographic research. And I had worked in hospitals where we have policy and guidelines for infection prevention and control, and then I came to Amrita, and working in a different context, in a different country and culture, really opened my eyes to how much we have to set our expectations to local practices, to social norms. This is just a picture of the outside of the ICU at Amrita Hospital, where one of the interventions is that people have to remove their shoes to go into the ICU, either to wear theatre shoes or over shoes, but somehow to remove one's outdoor shoes. And of course, this is a sign of respect, and I understand this. I come from Iran, so culturally I understand where this is coming from, but it's also a sign of cleanliness. But to me, it was also a sign of the number of people through this unmanned at any one time, and the traffic it generates, and how much that can contribute to infection prevention and control. So understanding context really is critical to us developing better interventions. I'm just mindful of the time. I have about 5 minutes. So antibiotic prescribing is a social complex. It is a complex social process. And this is the angle that we have taken in our research. And when we conducted research in the UK, we specifically investigated this across medical and surgical specialties in our hospitals, and we identified a set of rules that determine prescribing behavior, including this need for hierarchies influencing decision-making, the need for clinical autonomy, that physicians want to be able to make their own decision-making. So it again goes back to the fast versus slow decision-making and learned behaviors. But we often take an emotional interpretation of this, and we shouldn't. We should understand that different specialties, people with different expertise, will rationalize risk in different ways. And how can we better understand that? So through our research with the surgical teams, I'm much more comfortable to discuss this with surgeons about when I want to convince them about antibiotic resistance, is not to speak about antibiotic resistance and how many people it's going to kill, but about what it means for their patients. So what it means for the length of stay for their patients, what it means for the surgical outcome, because that's what the surgeons care about. And this was really nice for us to see this particular study, which Georgia Lamb and Georgina Phillips at the time were two of the surgical trainees when I was collecting the qualitative data in surgical teams in the UK. And they took on this research findings, and they developed with the surgical team a checklist for the ward rounds to be able to better communicate and highlight and sort of prioritize infection-related and antibiotic-related behaviors on the ward rounds. They were able to demonstrate a difference. They were able to, through this checklist, improve the communication, but also improve the outcomes for the patient in terms of quality of prescribing. So it is important to understand the context, but also it is important that we engage with educating people and spend efforts in education. So we did a survey across a cohort of learners we had around the world on a massive open online course we were running, and we asked them about what influences their decision making in terms of prescribing. And although antibiotic resistance was important, patient needs and senior colleague recommendations and personal experience were also important factors. And all of our learners told us that there isn't enough investment in training nurses and pharmacists, that culture, not microbiological culture, but social culture matters in implementation of interventions, and that there is poor surveillance. So we followed this up with a research study with colleagues in Amrita, with Dr. Sanjeev Singh, to look at the state of education and training around antibiotic microbial stewardship in Indian hospitals. And we had over 40 people specifically selected who had a role in antibiotic stewardship across India to participate in this research. And although a lot of them did report education and training on antimicrobial stewardship during undergraduate or postgraduate training, the overwhelming majority had received no training, on-the-job training for this, and yet the expectation is that people have to implement antimicrobial stewardship. So we have to spend a bit of time on investing in training and educating the experts, but also other healthcare professionals in antimicrobial stewardship. And that was a few years ago. We are now working with colleagues in India, and we've developed another massive open online course where we have expanded on the methodologies we're using in social science research and antibiotic stewardship. And we've come up with the same findings, is that there are still limited roles for non-physician healthcare professionals. There's lack of resources, including training and AMS, and there's limited knowledge on antimicrobial resistance across public and patient populations. Now, I know I've only got a minute left, and I know Dr. Singh has already gone through some of the fantastic work that our team is doing. We're collaborating with India and South Africa now, so I'm not going to talk through these slides because I know he's been through them with you, but it's just an illustration of the examples of work we are now doing to better understand how people rationalize their decision making. This was a study that was done by our colleagues in India, looking at antibiotic use in pediatric pathways and identifying how pediatricians rationalize antibiotic use and how they may use their fear of vulnerability in children to drive their decision making, particularly about this idea that children in India are malnourished unless proven otherwise. And this is in a hospital where a lot of the patients are actually well-to-do, and they are paying patients, and malnourishment may not be a problem. So it's interesting for us. It's important for us to be able to understand these drivers. Again, I think Dr. Singh has talked about that. I'm not going to talk about it, but I will finish on this slide. So this is about how we communicate. And as healthcare professionals, we still have a long way to go in effectively communicating about antibiotic resistance amongst ourselves, but also with patients and the public. There's been some excellent commentaries on this. This is by Professor Mark Mendelsohn and colleagues in Nature from a few years ago, where they sort of identified a mechanism for us to be able to better communicate around antibiotic resistance with not only amongst ourselves, but also more widely with other healthcare professionals and colleagues. And there's also some really nice studies being done by colleagues in South Africa around how does the public understand these terminologies that we use, and often there's a lot of gaps in understanding. And this is this study in South Africa used the minibus taxis community survey, which was fascinating, and I recommend people to read it. But as an anecdotal experience of my own, this is Peter Ahabwe, who is a wonderful pharmacist in Uganda with whom I've had the pleasure of working. He's such a knowledgeable and fantastic healthcare professional. And we were in a taxi in Kampala once, going from hospital to hospital, and we were having this conversation about how we engage on antibiotic resistance with the public. And I asked the taxi driver, I said, do you ever buy antibiotics over the counter? Because it is a big problem in many parts of the world. And he said, no, I have never in my life taken an antibiotic or ever bought one. And then Peter asked him, when was the last time you took Flagyl? And the taxi driver responded, I had it last Thursday for a bad stomach. So this for me was an example of how we need to really understand the ways we communicate with people around antibiotic resistance. I'm going to say thank you and stop there. And I'm so sorry that I went over by a couple of minutes.
Thank you, Esmita. You did not go over. It's absolutely fine. And thank you for such a wonderful presentation and talking about things which others are not talking. You know, mostly this is an area where you really need to kind of delve into the mentality or the socio-cultural aspect of people to understand how we can bring about the changes. Thank you so much. I hope you will be there for the question answer session, and I will definitely post the question answers for you. Thank you.
Thank you very much.
Well, my next speaker is Dr. Rama Subramaniam. He's a specialist in infectious disease. Hello, Dr. Subramaniam, are you there?
Yeah, I'm very much there.
Okay, thank you, thank you. Let me introduce you to the participants. He's a specialist in infectious diseases, adolescent and adult vaccinations, and travel medicine. He's currently a senior consultant in infectious disease, HIV, and tropical medicine at the Apollo Hospital in Chennai, in Tamil Nadu, India, and a professor of infectious disease at the SRMC Institute of Higher Education and Research, which is also in Chennai, Savita Medical College, and of course, a part of the Apollo Hospital Education and Research Foundation under MGR Medical University in Chennai. He has graduated from Madras Medical College, did his post-graduation from PGI in Chandigarh, and then went and did his MRCP from United Kingdom. He also has diplomas in tropical medicine and hygiene from London School of Tropical Medicine in genitourinary medicine from the Society of Apothecaries in London. After he returned to India, he has played a pioneering role. We all know about it, whom we have worked with him and listened to him also in establishing infectious disease as a specialty to India. I think he's one of the very few first ID specialists in India. He's passionate about infection control and has been instrumental in laying down the principles of infection control in several hospitals. He's the chair of the Infection Control Committee at Apollo Hospital, Chennai. He's an excellent teacher, excellent speaker, I can add that. And we have heard him in several conferences, and it's never, we always want more from him. In 2008, he founded Immune Boosters and Unique Clinic dedicated to adolescent and adult vaccinations and travel health. I think all of us understand the importance of vaccination in this era. The clinic, the first of its kind in India, propagated the concept of preventive health and travel medicine. He also established the Capstone Clinic, a multi-speciality family outpatient clinic in Chennai. So he will be talking about implementing antimicrobial stewardship in resource-limited settings. I think he has a very good experience, and I'm sure he'll share it with us. Over to you, Dr. Ram.
Dr. Sharmila, I think I sent you the recorded version. Is it possible to put it on?
Yes, I'll just ask Nikita, can you put on the recorded version, please?
Yes, ma'am, we'll be just sharing it.
Thank you. Nikita, no voice.
Good afternoon, everybody. It gives me great pleasure to join you this afternoon and speak to you about strategies for implementing antimicrobial stewardship programs in low resource settings. This cartoon very clearly illustrates the importance of context. For the question on the shortage of food in the rest of the world, the various countries, as you see, ask, what do you mean by food? From Africa, what is shortage? from Europe, what is the rest of the world in the United States, and what is opinion from Arabia. This may be a little skeptical, but at least conveys the message on the importance of how customization is necessary if you're going to put in place an intervention. These are my disclosures, and I have no conflict of interest. This map shows the resistance hotspots in various countries of the world, and you will find that this is especially marked in several countries of Asia, especially the South Asian and Southeast Asian countries and parts of Africa. We also know that it is believed that by the year 2050, almost 10 million people will die due to direct causes of antimicrobial resistance, almost 5 million in Asia and another 4 million in Africa. So if any intervention has to be targeted against antimicrobial stewardship, I think these places, which house several countries which are resource restrained, we need to ensure that programs are applicable in these settings. Applying the Pareto principle, 80:20, we have to understand that there are more people living within this circle than outside in the rest of the world. So whatever interventions we apply should be practical in these countries if it has to bear fruit. So targeting the antimicrobial resistance, over a decade ago, several organizations in the United States, the Society of Healthcare Epidemiology, the Infectious Diseases Society of America, and the Pediatric Infectious Diseases Society, along with the Center for Disease Control, came up with the intervention referred to as the antimicrobial stewardship, which refers to coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. To ensure that this was carried out adequately, leadership commitment, accountability, drug expertise, action, tracking, reporting, and education were defined as the 7 core elements of stewardship as per the Center for Disease Control. And to facilitate this process, an antimicrobial stewardship program team and its roles and responsibilities of various members were defined. And you'd see that the physician leader needed ID training, the pharmacist had to be trained in ID, there should be hospital epidemiologists along with quality management staff, microbiology involvement, and IT integration of this protocol to the existing workflow along with nursing support. To give you an example, a country the size of India with over 1.3 billion people has less than 100 infectious disease physicians. The number of pharmacists trained in infectious diseases is negligible. There are very few hospital epidemiologists, and the presence of IT in most hospitals in India is bare minimum at best. So when there is a lacuna in most of these aspects of the team, it is difficult to expect a good antimicrobial stewardship program in hospitals in India and other such countries. In other words, applying principles and protocols based on services like this, which you would find in Europe or the US, and expecting it to work in countries where this is reality is, I think, far cry from success. So what we need is customization of antimicrobial stewardship. As Modi mentioned to recently when he visited President Biden in the United States, we do not agree with your approach on antimicrobial stewardship. And we need probably customization to Indian requirements, and similarly customization to requirements of low resource settings. This is how I would view the plastic surgery in India. So I'm going to share with you my sentiments and my opinions on what I think would be appropriate based on over a decade's experience in putting antimicrobial stewardship in Indian hospitals. There should be an integrated approach, a combination of diagnostic stewardship, infection prevention stewardship, and antimicrobial stewardship. These three are the fundamental pillars on which the approach of antimicrobial stewardship should be based. So if we are going to impact on antimicrobial stewardship, it should have impact on the other two also. The first step is to educate the doctors that diagnosis is not everything in the management of patients. It is the only thing. Without a correct working diagnosis, we are not going to succeed in ensuring antibiotics are used appropriately. So how do you start with ensuring diagnosis is carried out correctly? Education on standardizing microbiology labs all through the country has to be carried out. Point of care testing should be encouraged. Rapid turnaround time and rapid test results should be the goal. In countries where there is resource restriction, time is money. Every day spent in the hospital with delayed diagnosis and inappropriate treatment is going to add to loss of money for a person who's working to feed his family every day. The reporting of cultures should be carried out by restricting the number of antibiotics listed. The less number of antibiotics given on the result, the better the antibiotics will be used. So all this will involve investing in diagnostics. So the first step in antimicrobial stewardship in resource limited settings would be to focus on improved diagnostics, quicker diagnostics to ensure that conditions requiring antibiotics are correctly picked up and then treated. Process and protocols have to be put in place. Simple steps to ensure that all hospitals compile their data on hospital-acquired infections, list the pathogens, put in the antimicrobial susceptibility pattern, starting with most susceptible to least susceptible to come up with an antibiogram, and most importantly, create an antibiotic policy should be stressed for all hospitals. Antibiotics should not be based on Western guidelines because they are irrelevant. Every hospital should create their own policy and come up with antibiotic guidelines. This is, I'm sharing with you our hospital antibiogram over 5 years ago, and you'll find that the ESBL prevalence in E. coli and Klebsiella are on the wrong side of 50. Carbapenemase production for E. coli was about 8% and Klebsiella about 30%, which has since then doubled. The occurrence of MRSA in my hospital still hovers between 25 and 35%. So this is significantly different from Western surveillance data, and hence our antibiotic approach should be based on this and should be much different from what you would see in the West. The concept of diagnostic microbiology tests amongst physicians have to change. Physicians still look at test results as what you would see in the picture, give you complete answer to all the questions they clinically want to know. And similarly, interpretation of diagnostic tests will also differ. The doctor asked me to spend at least 1 hour per day on the treadmill. So clinicians should be educated about the correct choice and interpretation of diagnostic tests, the importance of timing the tests. Very often, serological tests are done in the first 3-4 days and give wrong results. The choice of samples, sending urine from patient who has an indwelling Foley's catheter for several days may give erroneous results. Sending of endotracheal secretions in a person on a ventilator with normal chest X-ray, even though he has a fever, may be inappropriate. Sending of ulcer swabs without debridement and cleaning first, and depending on Manto and TB Gold tests to diagnose active tuberculosis should all be discouraged. The correct role of serological tests have to be explained. You'll be surprised that in India, still a majority of clinicians diagnose typhoid based on the Vidal test, a test which should be obsolete in a typhoid endemic country like India. The importance of sending adequate quantity of blood. Generally, 2 to 3 ml of blood is squirted into each bottle to color the culture media rather than get appropriate results. These practices should be discouraged. The absence of follow-up cultures, especially with infections like Staph aureus bacteremia and candidemia, may lead to inadequate therapy. empiric antibiotic selection should be guided not by choice of a magic bullet of an antibiotic, but dividing each infectious diseases problem as into two. What is a syndromic diagnosis based on which what the microbial etiology is likely to be. Once you decide on the syndrome, it is very difficult to get to the etiology based on medical evidence. And deciding the syndrome, the choice of the antibiotic becomes easier, especially when you apply local sensitivities. I would like to reiterate that applying guidelines of antibiotic choice from the West is not appropriate in a country like India or other Southeast Asian or even African countries, because the susceptibility patterns would be entirely different. Choice of therapy for nosocomial infections would also be different. Again, please decide on the syndrome before looking at the culture report. There is no test which will help differentiate colonization from infection. The local patterns of resistance, again, will be vastly different from Western guidelines. And stress that antibiotics should be empirically started only if the source is clear or if the patient is in severe sepsis. Following hospital antibiotic policy cannot be stressed harder. All these have to be regularly put across to the clinicians to ensure adequate hospital antibiotic therapy. Formulary restriction is an important part of antimicrobial stewardship in Western guidelines. But in India, where most hospitals, at least on the private side, are manned by fee-for-service consultants who have a significant autonomy, it is difficult to restrict antibiotics. So we came up with a novel solution whereby we resorted to the use of a high-end antibiotic request form on which you'll find the list of antibiotics. The justification for choosing an antibiotic as empiric therapy should also be noted, and this should be signed by the consultant. So we do not restrict the use of any antibiotic, however broad in spectrum it may be, but this form is reassessed in 48 to 72 hours to decide whether the choice of the antibiotic is justified for continuation. If it is not, an infectious diseases consult has to be obtained for justification. If neither of them work, the consultant has to stop the antibiotic. This gives the consultant the autonomy to decide on what antibiotic to use, yet in 48 to 72 hours, we bring in an impediment to ensure that continuation is carried out only if there is justification. The other low-hanging fruits would include de-escalation. People are still very, very worried to de-escalate even if the patient is improving and the culture report is available. So this is another area where confidence has to be given to the clinician regarding the microbiological results. And this is also easily achievable if the clinician is educated about this problem. We also know that the shorter is always better and more attractive. Shorter courses of antibiotics will significantly minimize the antibiotic usage, which is currently prevalent. Lastly, prophylactic therapy is another low-hanging fruit. People still use prophylactic antibiotics for patients in the ICU. People still use prophylactic antibiotic for patients with COVID with the fear that there could be secondary infections, even though we know that unlike secondary infections in influenza, which are over the tune of 50%, the occurrence of secondary infections in COVID is less than 10%. People are still worried. Using antibiotics for pyrexia of unknown origin without establishing the proper diagnosis just to stay safe also has to be discouraged. The choice, timing, and duration of surgical prophylaxis can also be reasonably well focused and targeted as low-hanging fruits. Surgeons feel that antibiotics will help not only prevent surgical site infections, but also prevent all infections in patients who undergo surgery. This myth has to be shattered. So all these can be achieved in resource-limited settings, but we need somebody to liaise with the clinician. I found in my 10-year experience in antimicrobial stewardship that communication is a very important part of restricting antibiotic use. To ensure this communication, we have in our hospital an antibiotic nurse who audits the use of all antibiotics, especially the high-end antibiotics. She monitors the justification written on these high-end antibiotic forms, which she also ensures are filled up. She informs the consultants on the use of high-end antibiotics and the justification needed. She is empowered to have a dialogue with these primary physicians and also monitor surgical antimicrobial prophylaxis and give a feedback on antibiotic use and compliance with various doctors. She interacts with the consultants to ensure that antimicrobial stewardship principles are followed. This is a much easier way to enforce the interventions rather than expect an ID-trained pharmacist or an ID-trained physician. If there is a problem, she always escalates it to us, and we bring it up to the Director of Medical Services, and we sort out the issue amicably. The last part of antimicrobial stewardship is to ensure adopting infection control. Adjustment with the right people is always better than argument with the wrong people. Diplomacy is something which I have developed phenomenally in my tenure as an infection control lead. We realize that isolating patients who are harboring either colonized by or infected by drug-resistant bacteria is a very important step in preventing spread of infections. So this should also be stressed. So the focus should be on fine-tuning the medical curriculum to ensure that this includes at least a few hours on antimicrobial stewardship, changing the exam patterns, because changing curriculum alone is not enough unless the examiner and the exam patterns are tuned to include this as an important part of their exams. Standardization of laboratories and diagnostic reports, simplifying stewardship program in hospitals, at least by ensuring cultures are sent and antibiotic policies are adhered to, targeting low-hanging fruits, modifying processes by integrating internists, microbiologists, and antibiotic nurse through better communication channels, and ensuring accreditation of labs and hospitals for standardization will probably be what we should look for in resource-limited settings. Lastly, innovation is most important. Our principles of innovation in ensuring antimicrobial stewardship has included limiting surgical prophylaxis to 24 hours, avoiding prophylactic antibiotics in general, except for surgery, sending cultures before starting antibiotics in adequate quantities, encouraging accurate diagnosis rather than empiric antibiotics, avoiding empiric antibiotics for fever in a hemodynamically stable patient, selecting empiric therapy based on guidelines, using the right dose, avoiding combination, de-escalation, and limiting duration of therapy. These are all feasible and very easily established in most hospitals in India. So it should be easy to do so in other resource-limited settings also. So I think if Professor Biden has said, let us agree to disagree as long as the goals are same, it is something we definitely have to do. The future of our children and grandchildren depend on how we use our current resources, which includes antibiotics, and innovating and customizing antimicrobial stewardship programs to suit low and middle income countries and resource restricted settings is very important. Thank you very much.
Thank you, Dr. Ram. It's very, very appropriate to the low, your talk was so appropriate to the low research setting, low resource setting. And yesterday there was a lot of question. We had a similar presentation, which was talking about strategies of ASP, but I think most of the questions which came up has been answered by you today. Thank you so much. And I hope whatever question comes up, you will be there for the question answer session. And I will definitely come back to you again. Thank you.
Sure, I shall be there.
Thank you. Nikita, is Professor Herman Gossens online?
He is, absolutely.
Yes,
Hello. How are you?
I'm good, thank you.
Okay, so let me have the honor and pleasure to introduce Professor Herman. He graduated as medical doctor in 1982 at the Free University of Brussels. He's a professor of microbiology at the University of Antwerp and director of Department of Clinical Pathology. in the University Hospital at Antwerp. He holds several expert positions in Belgium, the EU, the US, and WHO. Professor Gossens has more than 800 papers published in peer-reviewed journals, scientific journals, and was elected chair of the Scientific Advisory Board of the Joint Programming Initiative on Antimicrobial Resistance. He is the initiator of the annual European Antibiotic Awareness Day. With his translational research, he seeks to enhance the standard of healthcare quality, public health, and professional standards. And he is also a popular resource person and an opinion leader, much sought after the local and international media for view on matters related to public health and infectious disease. Just to add to this is my own take of Professor's work, is that he initiated the Global PPS, or the Point Prevalence Survey on Antimicrobial Use and Utilization. And I think just like hand hygiene is associated with worldwide with Professor Didier Pittet, I think Global PPS is associated with Professor Herman Gossens. Most welcome, sir.
Thank you very much, Sharmila, for your very, very kind words. And thank you also for inviting me. Also, Dr. Singh and Dr. Sharma. It's a real pleasure to be here this afternoon, and I'm also delighted with the invitation, because I think it's the first time that I will give a talk about antimicrobial resistance in the last 2 years, because I've been working on COVID non-stop like many of you, and so I'm delighted that I can finally once again give a talk about AMR and about the Global PPS. So thank you very much for inviting me. I will try to share my screen and see if that works.
Nikita, please, can you help?
So you'll see an option of share screen. Yeah.
Does it
visible
can you see
now?
my slides?
Yes, we can see your screen.
Okay, good. Is it in the present? Shall I put it in the presentation mode?
Yes, please.
Is that okay?
It's okay.
Okay, perfect. So once again, thank you very much for inviting me, and I will indeed talk about the Global PPS and how this can be used as a tool for data collection and data analysis. So I think all of you are familiar with the Review in Antimicrobial Resistance initiative launched by the UK government many years back. And these are the 10 fronts of tackling antimicrobial resistance, and one of them is on surveillance. And I also like to, when I talk about this review in antimicrobial resistance, I also like to refer to a quote that I have enjoyed very much, and I think it really summarizes what the importance is surveillance, and that is, if you can't measure it, you can't improve it. And the best person, of course, to talk about is obviously Lord Kelvin. So why measure antimicrobial use, and what is the purpose of doing surveillance? And it's not just to describe current practice or current prescribing practices, but it's also because it allows you to do many other things. And I think surveillance just for the sake of surveillance is not enough. I think we need to go beyond that. And so what you can do is, when you measure antibiotic use or antimicrobial use, you can measure the monitor and you can measure trends over time, or you can monitor trends over time. You can compare, for instance, wards in hospitals. You can motivate healthcare providers, and I think that's one of the things we mostly enjoyed when we did point prevalence surveys. You motivate healthcare providers. They realize that there might be an issue with antibiotic use in their hospital, and that would then trigger some interactions or some initiatives or interventions. And indeed, that's the next advantage or purpose of doing surveillance, and that is you can design your targeted intervention, and then you can eventually, of course, also evaluate the impact.
Please
now,
share yours. Put it on the presentation mode, slide presentation mode.
It's on slide presentation mode on my screen.
We are not seeing it. We can just see the first slide only. Can you just take your cursor to the
so you don't you only see the first slide?
Yes, we only see the first slide.
And now it doesn't move?
No, it's not moving. Nikita, can you help?
Yeah, maybe if you use a PDF file, then I can stop sharing. This is strange.
So you can start the slideshow mode on.
So I have stopped sharing now.
Yes. Nikita, can you guide, please?
So now you can start screen sharing and you can start the slideshow option in the presentation.
Yeah, but can you maybe show the PDF file that I sent this morning?
Yes, Nikita. Will you just follow the PDF file which Professor Gossens has sent?
Yeah, so shall I share it?
Yeah,
Yes,
please do.
do.
Yes.
Okay.
Yes.
Somehow it doesn't advance my slides. I don't know why.
It's okay. We'll do it.
Super. Yeah. If I have the next slide. Yeah. The next slide, please. And the next slide.
Yes.
And the next slide. Yes. So the Global PPS actually started back in 2006. It was funded by the European Commission as part of the European Surveillance of Antimicrobial Consumption project, and it became global in 2015 thanks to an unrestricted grant from BMWU. And since then, we have been repeating point prevalence surveys annually, and we invite hospitals to participate in up to 3 surveys per year. Although I have to say that over the last 2 years, many hospitals, of course, had other priorities, obviously because of COVID-19. And so we hope to accelerate the point prevalence survey in 2022. And we are now planning, indeed, a survey early next year. Next slide, please. So what are the aims of the Global PPS? Well, first of all, our aim was to develop a valid, feasible, and sustainable surveillance tool that allows you to monitor rates of antibiotic use, but also resistance, because we not only collect data on antibiotic use, but also on resistance in patients admitted to hospitals. And so these are adults, children, and also neonates. We want to determine with this PPS tool the variation in drug those indications of prescribing and this across the continents. And then we want to, based on this data, identify targets to improve antibiotic prescribing, but also to prevent healthcare-associated infections. Because in the basic module, we do have some questions about healthcare-associated infections, but a couple of years back, we added an optional tool with a lot more data that we can collect on specifically healthcare-associated infections. So that is a new that's a tool that we added a couple of years back as optional of the Global PPS. It then helps you to design prescriptive interventions. You can assess the effectiveness of intervention if you do repeated point prevalence surveys, and also it raises awareness on appropriate antibiotic prescribing. Next slide, please. Next slides. Yeah. So what are the features of the Global PPS? It allows you to use this uniform standardized methodology. We wanted everything to be web-based. And so it is indeed a simple web-based tool that you can use for data entry. There are some data validation steps behind this data entry. And also you can get, if once the data have been validated, you can get automatically a feedback of the of antibiotic prescribing patterns in your hospital. It's freely available for all hospitals, and participation is on a voluntary basis. Next slide, please. Next slide, please. Yeah. So what is required to participate in the Global PPS? Well, basically, it's very low. Let's say the threshold is very, very low. So every hospital worldwide can participate. And there's also the possibility to participate not only as an individual hospital, but sometimes hospitals are part of a network. And of course, that network can also participate, and then they collect data not only for their hospital, but also for the network. So there's a kind of flexibility built in the system. What are the benefits for the hospital as a hospital network, where you can centralize the data entry, and also you can obtain aggregated results, And that is sometimes interesting, particularly for smaller hospitals. And that is, of course, the downside of PPS. If you're very small hospitals, the numbers are very small, and then you need to be very careful about interpreting the data. And that is certainly an issue in wards for children and for neonates, where you may have less patients, and therefore you need to be, again, careful about interpretation of the data. I can have the next slide, please. So this is basically how it's done. You have patients in surgery ward, in ICU, and in the medical ward. We start counting all the admitted patients at 8 a.m. on the day of the point prevalence survey. It's a point prevalence survey, so we look at a specific time point. That is 8 a.m. on that particular day. Then we count all the patients antimicrobials on that particular day. So the denominator is all the admitted patients. The numerator is the patient's antimicrobials. And then you can start collecting those patients who are receiving antimicrobials with the red dot. And that's where we have the basic form that you can fill in. And on the next slide, please. So this is the basic form. It collects detailed numerated data only for those patients on antimicrobials. So it looks at prescription data. It looks at quality standards, and I'll come back to this. And then it collects also data about resistance rates, so and whether then patients are treated with or have a targeted treatments for specific antibiotic-resistant bacteria, or whether this is more empiric. So all these kind of data are then also collected on the basic form. Next slide, please. So let me now give you examples of how you can use these data that you've collected in the hospital to develop antimicrobial or antibiotic stewardship actions. Next slide, please. So to enhance the quality of antibiotic prescribing to stewardship activities, there's several things that you can do. You can identify targets for quality improvement, and I will explain what kind of targets we have developed for improving antibiotic prescribing based on the data that you collected in the Global PPS. You can set a timing, you can plan your intervention, and then you can effectively measure the impact of the interventions through repeated point prevalence surveys. And later on, I will show you an example of one Indian hospital that has repeatedly done the point prevalence surveys, and to give you some ideas of what how that can help you to improve antibiotic prescribing. Next slide, please. So these are the quality indicators that we developed in the Global PPS, and we try to keep it very simple. So the whole methodology is very simple, but also quality indicators should be very easy to identify. So, for instance, we collect data on whether the documentation of the reason for antibiotic prescribing is in the notes. So therefore, whether the doctor has actually written down in the notes why the antibiotic has been prescribed, whether there's a stop or review date written in the notes, whether there's guidelines are missing for this particular indication, and if there's a guideline, whether this is then compliance to the local guidelines. You can look at the amount of broad spectrum antibiotic prescribing. You look at the amount of antibiotics that are prescribed parenterally. You can look at the number of antibiotic combination therapies, and you can also look at whether the antibiotic prescription or the antibiotic that has been prescribed is targeting a certain bacteria, or whether there's a lot of empiric prescribing. Next slide, please. Some more indicators, just simply looking at the prevalence of hospital-acquired infections. And as I said, that's part of the basic form, but we also develop an optional form where we collect a lot more detailed information about hospital-acquired infections, whether targeted prescribing, whether the targeted broad-spectrum antibiotic prescribing for hospital-acquired infections, whether the broad-spectrum antibiotic prescribed for surgical prophylaxis, and that's a very important quality indicator. And then another even more important quality indicator is prolonged antibiotic prescribing for surgical prophylaxis, and that is a low-hanging fruit, if you like, in the Global PPS to improve antibiotic prescribing, because that is obviously very well standardized also globally, and there's very little discussion about the duration of surgical prophylaxis. Next slide, please. So a few examples now from the feedback that we received from a particular hospital in India, from hospitals in India, but then focusing on one particular hospital that has done 5-point prevalence surveys. You can have the next slide. Next slide. So before discussing the example of this particular hospital, I'd just like to explain what WHO has proposed several years back, and that is the AWARE classification. So this is an acronym for Access, Watch, Reserve, and not recommended antibiotics. And so basically a very simple classification that WHO has developed that you can use for assessing the quality of prescribing in hospitals. Access means that these are the first or second choice of empirical treatment of the most common infections, but there's obviously a lower risk of also resistance selection. Watch means that these are first or second choice for limited indications only, maybe with a higher risk of resistance selection. And then the reserve antibiotics are those that should only be used as a last resort when no alternative antibiotics are available. And then more recently, 2019, WHO added another category, the non-recommended category. And these are all kind of, let's say, weird combinations of broad-spectrum antibiotics that should not be combined, such as, for instance, cefoperazone, tazobactam, or amoxicillin with the flucloxacillin, or ceftriaxone with sulbactam. Next slide, please. So these are data we published earlier this year in the Journal of Antimicrobial Chemotherapy using the AWARE classification to assess antibiotic prescribing in hospitals globally. So these are data from all over the globe. And if you look particularly at Asia and then more particularly at India, focusing on India, you can see that for the data that we collected from those Indian hospitals, there was a considerable number of antibiotics prescribed belonging to the reserve or not recommended AWARE category. So that could trigger certain actions. This might be justifiable, but it could also mean that you need to understand why is that so. And again, maybe that's justifiable, but maybe it's not. And then you can set, of course, or you can organize an intervention to reduce the antibiotics used on the reserve list or on the list of not recommended. Next slide, please. Now, this is an example, again, of this particular hospital, looking at the AWARE classification. And in that particular hospital, there was indeed high number of, or let's say relatively high number of antibiotics that were on the reserve list. And so this is actually comparable, but the other hospitals that from which we collected data in India, and it is indeed higher from other hospitals in Southeast Asia, from tertiary hospitals, because this was a tertiary care hospital, and it's also higher than hospitals where we collected data in Europe. So these were data for nearly 200,000, nearly 20,000 prescriptions. Next slide, please. And then that hospital started looking at which antibiotics were prescribed on the reserve list, and then you can again compare your own hospital with the hospitals in the particular country. In this case, this is India. And so what they discovered in this hospital was that they use a lot of colistin. And again, that could be perfectly justifiable based on the kind of infections that were encountered in that hospital, but also it could mean that indeed this was a reflection of inappropriate use of colistin. Next slide, please. So you can also look at, for instance, the number of healthcare-associated infections. And this particular hospital, same hospital, they had a ward for children and neonates. And although, again, the numbers are low, because that can be the case in hospitals where you have more adults than children and neonates. But in this hospital, they noticed that the rate of healthcare-associated infections was reasonably high. It was higher than the rate for the country, for India. It was also certainly higher for what we see, for instance, in Europe. And in this case, in our database, we found that 5.7% of infections were healthcare-associated infections in European hospitals. And then you can look at why was this so? And in this case, it was obviously related to interventions. And in the optional module that was used afterwards, you could then see whether this is catheter-related or any other interventions that could explain these healthcare-associated infections. Next slide. So the same hospital looked at, for instance, the amount of parenteral use and noticed that they actually used a lot of antibiotics intravenously. And actually, most of the antibiotics in that particular hospital were indeed used intravenously. That was higher than for the Indian hospitals from which we collected data. It was higher than for Southeast Asia. And it is also higher than hospitals that belong to the same type. So this was a tertiary care hospital. And it was a lot higher than what we see, for instance, in Europe. So, and again, if you see that you're in a hospital where you use a lot of antibiotics parenterally, there could be a reason for that. But if that's not the case, you can then launch a stewardship program to reduce intravenous use of antibiotics. Next slide. They also looked, next slides. They also looked at, for instance, the antibiotics used for surgical and for medical prophylaxis. And here you see the data for this particular hospital for medical prophylaxis. And what they realized was that they used a lot of third generation cephalosporins and carbapenems for medical prophylaxis. And that's obviously mostly in hematology and oncology patients. And they realized that this is something that they were not really aware of, but that may not necessarily be something that you can justify. Next slide, please. And then finally, they looked also at surgical prophylaxis, again, this particular hospital. And when they started doing the first point prevalence survey in 2017, again, the numbers are low, but they realized that all of their patients, when antibiotics used for surgical interventions, they received antibiotics for more than 1 day. So they decided to reduce or try to reduce this, and then had several interventions. And you can see that they managed to reduce the proportion of patients receiving antibiotics for surgical prophylaxis more than 1 day, except 2020. It's a bit of an odd year, also for the data we collected in India. Maybe it has to do with the COVID-19. That's something we need to explore later. But in general, this is a success story in one particular hospital trying to reduce the duration of antibiotics for surgical prophylaxis. Next slide. We did another study that we published this year about the impact of the Global PPS on hospitals' antimicrobial stewardship programs. We wanted to understand with this worldwide survey, are hospitals using this successfully? Are they using the data? And are they using this as a component for antibiotic stewardship? And so we sent this questionnaire to 248 hospitals in 74 countries. And we were very pleased to see that in nearly 97% of the hospitals, they were able to identify targets to improve antibiotic prescribing based on the Global PPS. And that they actually not only identified these targets, but also use this as a component for antibiotic stewardship programs in 70% of the hospitals, and then in 43% of them, they had a formal AMS strategy. So what we also noticed, and probably not unfamiliar to you, is that the lack of time, knowledge, and good prescribing practice, and particularly funding, were identified as the most common barriers to implement antibiotic stewardship programs. Next slide, please, and I'm coming to the end. Yeah, so Global PPS has indeed been very successful, Sharmila, and that has resulted in many publications. And this is one, for instance, with Dr. Singh, with Indian hospitals, but yeah, many hospitals globally have participated in Global PPS, and that has resulted in many of these publications. Next slide. And so what are the benefits? Well, it's a common methodology and uniformity of data collection. It's a simple protocol and tool for data entry and data validation. So therefore, it's a feasible surveillance tool with a quality assurance process behind it. And then it's we also have a support team in Antwerp that gives support for free. And also we provide local training or support through webinars or teleconferencing. Data collection and data entry questions can be addressed through the help desk, frequently asked questions, or the IT manual. And then again, we help with publication and data sharing if needed. The final slide. So yes, you're very warmly welcome to join us in 2022 and beyond. And so I thank you very much for your once again for inviting me and for listening to my presentation. Unfortunately, I had a meeting in a hospital after this one, so I cannot stay for the Q&A session. But if there are any questions, I don't know if there's any time now or otherwise, please send me an email, and I will be very happy to answer your questions by mail. So thank you very much for your attention.
Thank you so much, Professor Gossens. I think we have participated in your Global PPS, and I know how simple it is. And especially in resource-limited settings, we've been able to just train one of the nurses to collect the data, and she can do it. So I understand that I'm sure you will have a lot of queries from our participants who are still not aware of this Global PPS for antimicrobial utilization study. And please go ahead with your appointments. I will definitely get back to you with any pertinent questions which come up from the participants. Thank you so much.
Thank you very much, Sharmila, and good luck with the meeting. Thank you very much.
Thank you. Thank you.
Thank you.
Well, let me introduce our next speaker, Dr. Surbhi. Dr. Surbhi Leekha, she's a good friend, and she's going to talk about monitoring, data collection and analysis, evaluation and feedback, the way forward. So welcome, Dr. Surbhi, and let me just introduce you. She received her medical degree from All India Institute of Medical Sciences, followed by a Master's of Public Health in Epidemiology from University of Massachusetts, and she completed her internal medicine residency and infectious disease fellowship at Mayo Clinic in Rochester. She's an infectious disease physician and serves as a medical director for the infection prevention and hospital epidemiology at University of Maryland and Medical Center. Most of her time is devoted to day-to-day hospital epidemiology practices, conducts research and surveillance and prevention of healthcare-associated infections. She has a particular interest in surveillance methodology and implements of practices to prevent infections. She's interested in appropriate use and application of infectious disease diagnosis as a means to antimicrobial stewardship. Since 2018, she has been leading the Maryland State Prevention and Reduction Collaborative, SPARC, for the healthcare-associated infections that started with the prevention of Clostridioides difficile infection and has focused on COVID-19 since the pandemic. Welcome, Dr. Surbhi. Nice to see you after a long time. Yes.
Thank you very much. It's such an honor to be here. And, I will say, hearing the last two speakers, I think they made my job easy. You'll hear many of the same themes repeated in my talk, with a special emphasis on the PPS methodology. So let me see if I can share my screen here. All right, give me 1 second.
On your left-hand corner.
Yes, it's just can't get back into the PowerPoint.
Yeah. Don't worry. You just have to go to your left-hand corner on the top where you have the PowerPoint presentation and click. A little up and further left. A little up.
We're here?
No, next, towards your right. No, go up. Go up.
Oh.
Have you seen it? Yeah, you're just.
Oh, right there, right?
Yes,
okay.
Yes.
I should know this by now. How many, but every time it's taught.
Okay. I am in the same boat, if not on a worse boat.
Okay, so the title of the talk is Tracking Data and Using Data for Improvement in Antimicrobial Stewardship. And you heard this from Professor Gossens very well. But the outline of my talk is, what are the types of measures that we use in antimicrobial stewardship programs? What may be some of the barriers and potential solutions? And one of them really being, doing a PPS when you can. And then, a big point to be made about using quality improvement frameworks and the role of data when you're trying to implement quality improvement or QI projects in antimicrobial stewardship. So again, this was said very beautifully, why do we need to measure? Why do we need to track data? Measurement is very powerful. What you cannot measure, you cannot improve, right? And we know this from decades of experience with doing surveillance for healthcare-associated infections. Even if you're not doing anything, just measuring and giving the feedback on the data, people will start paying attention and start to do something about it. And with respect to antimicrobial use, there are really two main goals of doing this surveillance and measuring and tracking. The first is to identify opportunities for improvement, and the second is to assess impact of those interventions. So what should be measured? One thing I will say that, we've come so far along, both in infection prevention and antimicrobial stewardship, and I certainly have, much of the US perspective, but to date, what do you measure? What are the best measures for antibiotic stewardship programs still remains debated. There is no great consensus. And the reason this is because the care of patients who are suspected to have infections is very complex, and the decision making on what antibiotics to use for how long, what doses is complex and nuanced. Also, the downstream patient outcomes that we think are important as the pertinent outcomes of antimicrobial use, particularly antimicrobial resistant infection, they may actually be not as frequent, which is good. And they also have multiple causes, right? So you may see transmission in the hospital causing multi-drug resistant organisms, and you see antimicrobial use. So how do you know what's causing what? So all of that needs to be taken into consideration. And the last one, of course, and I think all of you face this, is that the effort required to extract and analyze antimicrobial use metrics is very high. So what we'll do is we'll just go through some of the pros and cons of the different measures, but you really have to think about what you can do in the context of your program, where you are. If you're already a very evolved program, then you can try to refine and add more metrics. If you're not and just starting very early, then as Professor Gossens mentioned, keep it simple. Okay, so what are the different types of antimicrobial stewardship measures? I think in my mind, I like to classify them in these three different buckets. One is the process, so of antimicrobial stewardship, and you're trying to measure two different things. One is the quantity, and the second is the quality of antimicrobial prescribing. And the question you're trying to answer there is, are the policies and guidelines being followed as expected? The second is the outcomes. That's what we care about. What is the impact on antimicrobial resistance? In North America and in Europe, C. difficile infection remains a very important outcome, but that may not be relevant in your setting if you're not seeing that as a problem of antibiotic use. And there may be other safety outcomes. So the question we're trying to answer here is, did your interventions improve antibiotic use and patient outcomes? And lastly, there's one other set of measures that are just programmatic measures, and those may not be as attractive for you to measure because they're not really telling you about the process or outcomes of the program, but that may be important to those who are paying you or providing the resources. So the question there is, what are the interventions that you're making, and how are you saving costs to the hospital, for example? In the US, that's a big deal, and we often have to keep track of those metrics as well. So we'll just do a brief overview of the different measures, so at least you have an idea of the different things that are out there and can be measured. So starting with the quantity of antimicrobial prescribing, there are three commonly used metrics of quantity or consumption. You can either see defined daily doses of antibiotics, or you can see days of therapy, and we'll talk about the difference between those two. And a third, because often the first two are difficult to measure, is just the cost of specific antimicrobials. And all of these three measures can be normalized to patient days, right? They can be expressed that you're using certain number of doses for every 1,000 days of inpatient stay in the hospital. What are the different sources of these data? So you can get them through ordered doses. You can also get them through actual administrations. And this tends to be the most accurate, but this is often the hardest to get, right? It really involves getting those data through patient charts, whether those are electronic or paper charts. And the third is just using the business or cost data or pharmacy data of acquisition of these drugs, which is probably the easiest to obtain, but tends to be less accurate. It also may not be relevant depending on who's bearing the cost of these drugs in your setting. So let's talk a little bit more about these different metrics. I'm just going to try and minimize. Okay. So the defined daily doses, or the DDD, you will see this often in many publications. So that is amount of drug a typical patient might receive on a day, right? So if there are some medications that are 3 times a day, then it accounts for those multiple doses a day to record the doses for that antibiotic. And this is relatively easy to obtain from dispensing data. The problem is that if you're looking at total antibiotic, it biases against combination therapy. So for example, if you're using a combination of ceftriaxone and metronidazole, which actually is preferred over something that a broad spectrum such as meropenem, the total DDDs would actually be greater because now you're using 2 different antibiotics to achieve the same result as opposed to one. Days of therapy is a little different, where each day the antibiotic is given is counted as 1 day, and that's regardless of the dose. So it's a little more intuitive, but harder to obtain because it does require looking through medical record data, or getting automated data dumps to record those. This may also have the problem of double versus single counting, just like the DDDs, when the patient is receiving 2 antimicrobials on a given day. So you really have to think about whether that combination is a desired combination, or it is an inappropriate combination, as you heard in the last talk. And then the last one is the cost of specific antimicrobials, which may be easy because your pharmacy purchasing data can help you get that. But it does not work if the patients, for example, are paying for the antimicrobials, which may be true in your setting. So, you really have to be careful on what you're selecting, depending on the setting in which you practice. So how do you then choose and use the antimicrobial use or quantity metrics? I think you really have to pick the most feasible to start. And that's probably the best advice is, just as long as you make sure that you're measuring it consistently using the same methodology, it does not matter which one you pick. Because what you'll see too is that your own internal measurements that are taken over time and monitored are of much more value than external benchmarks. Also because those external benchmarks are very few, and we'll talk about that as well. Some considerations is, you can do it house-wide. Now, this really depends on the size of the hospital or the setting. So if you're a very small facility, you're probably better off doing it house-wide. But if you're a large hospital or tertiary care hospital, then obviously, you need to focus on specific units or wards. Do you want to use all antimicrobials or targeted? Again, you heard this very nicely. If you use the WHO aware, tiers, that's one way of classifying. But most will recommend tracking use of broad spectrum agents, knowing that that's where the money is, because we don't want overuse of those last resort or broad spectrum agents, particularly carbapenems and the anti-Pseudomonas drugs. But again, it has to be guided by the local context and feasibility of getting those data. So this is just one example of tracking use over time. Again, in this example, they're using the DDDs per 1,000 patient days, and you can see that you can actually chart different antibiotics and see what's going on over time. In this case, increase in use of the beta-lactamase inhibitor combinations, decrease in fluoroquinolones, and you can see whether or not that relates to what you expected to see, or is that against what you expected to see in your setting. But let's talk about the quality of antimicrobial prescribing. And this was also covered very nicely, as the quality indicators as discussed by Professor Gossens. But one thing I will say that, this antimicrobial, the idea of appropriate prescribing of antibiotics or antimicrobial appropriateness is really a key measure, right? That's what we're trying to say, is that we want every patient to get antibiotics in an appropriate way. So it's considered a key measure, and theoretically it's very appealing, but practically, because of all the subjectivity involved in prescribing antibiotics, it's often elusive. It is also resource intensive and requires expertise to make those assessments, and there are no standard definitions of appropriate. So how can you overcome that? So again, aiming small for doing some of those detailed qualitative reviews, relying on point prevalence surveys or focused areas of use, And these are very good for quality improvement initiatives because you can measure the total and the quantity of antibiotic use, but doing the qualitative reviews really helps you understand the why of suboptimal prescribing. And this was also emphasized by Professor Gossens, and I'll make this point over and over again, is your best friend is probably hospital guidelines. When you have hospital guidelines, not only does it help you in your implementation endeavors, but it also helps you to measure appropriateness. So, measurement may be an incentive to establish those guidelines. Otherwise, you can also create agreed upon definitions or algorithms. So the US CDC has some nice materials also on implementing antimicrobial stewardship. And they have examples of assessment of appropriate use. This is one in the inpatient setting, and I only took a picture of half of it. But again, basically, was an indication documented? Were cultures collected? If no organism was isolated, were antibiotics stopped? And there are several other assessment items. So there is a lot of material available that you can either modify for your setting or participate in the Global PPS platform that already has some of these items in that structure. So I talked about the program assessment. So, you've done the quantity of antimicrobial use, you're looking at the quality of antimicrobial use, but then you also want to measure the impact, right, that your program is having. And one of those things that you want to measure are just program related measures, because it is important in the end to show value of the program, right? How do you say that it's justified to have this antimicrobial stewardship program, to justify the resources, whether it's people or infrastructure, IT, to measure things. So again, this needs to be tailored to how your program is implemented. So an example being, let's say that you use the prospective audit and feedback methodology, right, where the antibiotic nurse or the antibiotic pharmacist is 48 hours after prescription reviewing that and then providing feedback. And so what you can measure then is the number of interventions that were recommended and the proportion that were accepted. So you can go back to your hospital leadership and say, okay, we made X number of recommendations over a period of month, and that resulted in improving the prescribing in 50% or 60% of those cases. If you're using antimicrobial restriction as a method, how often do prescribers override that, right? So those are all measures of how your program implementation is going. And then sometimes, this in US hospitals, this is asked a lot, are you saving cost? And you should be, particularly if you're reducing the prescription of broad spectrum drugs, or you're reducing the emergence of antimicrobial resistance and causing less harm to the patient through hospital-acquired infections. But the final impact that everyone's really interested in is that on patient outcomes, particularly with respect to infections with antimicrobial resistant organisms. That is that desired end goal of ASP, right? That's why we're all here. So what we measure then are the incidence rates of specific antimicrobial resistant organisms based on the clinical culture data, or facility antibiograms, where you're looking at the % resistant of the total numbers of cultures. I will say that these are related, but these are complementary. So, two complementary measures. How many cases of an antimicrobial resistant organism are we seeing? And what proportion of that organism of interest are antimicrobial resistant? So, just to give you an example, let's say that, you can tell me, oh, in our hospital, 50% of staph aureus are MRSA. Well, that's high, or, that's normal now. But you can also show that over time, the incidence of infections with MRSA is going down, or it's pretty low. So those two are complementary information. And I'll show you another example of that. But the question is, which organisms should we be monitoring? If you look at older data, people would look at ESBL and MRSA, and now those are pretty endemic in the community in most places. So they've become less useful because, it's so widespread in the community. When people come in, it's expected that, MRSA will be causing 50-60% of all Staph aureus infections, or ESBL is very common among the Enterobacterialis. So, it is recommended that, looking at those with higher levels of resistance, so carbapenem resistance in Enterobacterialis or, CREs, and multi-drug resistance in Pseudomonas and Acinetobacter are recommended by most experts as targets for, which organisms you want to monitor. As I mentioned, C. difficile is pretty common in North America, in Europe, and generally recommended as well, but that may not be true in your setting. But the key points there are that these, which organisms you pick should be evaluated in the context of the local infection prevention and control program. So you definitely need to partner with that. Also, because their prevalence is influenced by both antimicrobial use and infection prevention practice. So when you go about, designing your interventions and trying to reduce the rates, you really have to be mindful of how you're targeting and what you're targeting. So the organism and resistance mechanism you pick should be guided by the intervention. So I wanted to show you a couple of examples. This is a study that we did at the beginning of the COVID-19 pandemic. So, we looked at antibiotics commonly used for treatment of pneumonia in early COVID-19, because, when testing was not as easily available, patients came in with pneumonia, everybody got, antibiotic treatment for pneumonia. And then we also looked at the incidence of multi-drug resistant gram-negative organisms during the same time period. So we compared the 2020 time period with the same time in 2019, and noticed an increase in the use of pneumonia antibiotics in 2020 compared to 2019. And then in the same time, this is the graph below. Oh, actually, maybe I got the wrong graph there, but we also saw a pretty good increase in multi-drug resistant organisms during the same time period. But we partnered closely between antimicrobial stewardship and infection prevention, because we identified gaps in both programs and realized that the increase in MDR gram-negative was the result of pneumonia antibiotic overuse, but also spread those organisms in COVID-19 units because of different infection prevention practice during the pandemic. Okay. And then, I also wanted to show these two from another publication, the impact of selective reporting on resistance. So, how you pick what you're measuring. So in this study, this is from Canada, they introduced selective reporting of susceptibility to fluoroquinolones among Enterobacterialis, meaning they would only report fluoroquinolone susceptibility if it was resistant to other antibiotics, right, as a means to limit fluoroquinolone use. So they tracked the fluoroquinolone use expressed as DDDs per 1,000 patient days, along with the use of other antimicrobial agents. So, here the dark black line is ciprofloxacin, and then, then you have the other antibiotics in the other other lines. And they also tracked incidence of E. coli and Pseudomonas aeruginosa, as well as the proportion of E. coli and Pseudomonas isolates susceptible to fluoroquinolones. So again, remember, we said that that provides you complementary information. So you're looking at both the incidence of, how commonly those are occurring, and also what proportion of isolates are susceptible to fluoroquinolone. So over time, what they saw is decrease in fluoroquinolones, so specifically ciprofloxacin, come down after their intervention. They actually saw somewhat of an increase in the use of amoxicillin clavulanate, which they expected. That was an expected outcome. They saw an increase in fluoroquinolone susceptible E. coli, but not in Pseudomonas. So again, as expected, that's what they were seeing, as well as a decrease in the incidence of fluoroquinolone resistant E. coli. So, beyond antimicrobial resistance outcomes, there are also other patient safety outcomes that can be targets of antimicrobial stewardship programs. So that gets a little bit out of the scope for this talk, but please do keep those in mind, right? Especially for the pharmacists, adverse drug reactions, toxicity, and readmissions for adverse drug reactions are all important and help you make the case for antimicrobial stewardship programs beyond the impact on antimicrobial resistance as well. So let's talk about benchmarking. And again, this is complementary to the previous talks as well. So you can have external comparisons. We all aim to do that, or you can have internal comparisons. I will say that overall, external comparisons are limited. But so you will need to seek or develop external partners, including collaboratives that exist at the state or regional or national level, or as was previously pointed out, at the international level, such as the Global PPS. But if you don't have access to that, or that's too much to do, or cannot occur that frequently, obviously, you can always do internal comparisons. So hospital-wide over time. So you're just saying, well, how am I doing today compared to back in 2019 or 2020? Or across similar hospital units. So, comparison of hospital units or service lines or physicians, you have to be just careful that they're not, completely different in the populations they serve, because those comparisons can sometimes be not very appropriate. But if you have similar hospital units, if they serve similar populations, then absolutely you should be looking at those very carefully. So what are some of the barriers to measurement and tracking and some potential solutions? So we all suffer from lack of having enough resources dedicated to these programs. So if you don't have enough people, make sure that you're looking at least at focus specific areas by finding those targets that may be most important. Partnering with infection prevention and control, partnering with the general pharmacist in the hospital, finding unit-based champions, or the unit-based nurse or physician who is willing to be part of the quality improvement project. If you lack IT infrastructure, again, this PPS keeps coming up. I think that really is key to making improvements. And anyone, when you're starting out, if you can do nothing else, please do a PPS. As I mentioned, there's always a challenge in defining what's appropriate antibiotic use. So developing facility-specific guidelines helps you assess appropriateness of use against those guidelines. So this is just an example. Again, I think this is complementary to what we discussed in the last couple of talks, but using PPS data for tracking and feedback, here I just marked up an example of, you have your measures, you can have your baseline for two different service lines, right? The medical service line compared to the surgical service line, and then you can follow up at whatever frequency you're doing, once every quarter or once every 6 months. How many patients were surveyed, how many were on antibiotics, how many had the documented indication, how many were compliant with the guideline, how many were compliant with surgical prophylaxis less than 24 hours. And you can feed these data back to the stakeholders. So I will move on quickly to this last part of the talk, which is using quality improvement framework for implementation and the role of data and measurement there. This is something I feel very strongly about. This is the way forward. That's the way to improve, is you find a focus or a target for improvement, set goals that are SMART, and I'll tell you what that means, and then do some detailed action planning step by step, and then realize that data are important at each step, but the type of data you collect depend on the focus of the intervention. So this was also mentioned by Professor Gossens, but how do you find those areas of focus? Again, that has to be specific to the setting, but some of the examples are prolonged surgical prophylaxis, if you're treating just any positive urine cultures, empiric treatment of sepsis in the ICU. How do you find these areas? Again, same thing, evaluating the antimicrobial use against hospital guideline, particularly using the PPS strategy. Now here, it's, really if you do a hospital-wide PPS, that's labor intensive, but probably worth it because it gives you such complete data and also gives you more robust numbers. But you can do, if you're completely strapped for resources and don't have the ability to start small, just with targeted PPS or audits, maybe 20, 30 patients to start. But again, be careful in the interpretation if the data are limited. But when you do those repeatedly, that does add and help you understand what's going on over time and whether those practices are sustained or just a one-time thing. Also consider the impact. So, if you were to address the harm, so if you have prolonged surgical prophylaxis, that would seem important. Is it likely to impact patient safety or not? And then finally, you have to consider the resources and how ready your staff are for that change. What is realistic and what is achievable in that given time period? So the two next things are then to set your goals and then define the steps for the way forward. For goal setting, this acronym is very useful. So setting a SMART goal, make it specific, make it measurable, achievable, relevant, and time-bound. And then when you're planning, make sure your steps are very specific and you have the measures that tell you when each step is achieved. So let's just walk through an example of how you find a focus area and then develop those SMART goals. So you looked at the dispensing data, that's all you did, and you find that there's very high use of imipenem in the surgical unit compared to other units. Well, so that's not okay, right? It's a broad spectrum antibiotic and looks like this one unit is an outlier. You do a focused PPS and you find that the most common indication is UTI. And you try to look at the appropriateness of that indication, you realize that that's not okay because most of those patients are asymptomatic, but they have positive urine cultures where the treatment was not really necessary. And that was done because they are doing routinely UA, urine culture sensitivity, routinely in the pre-op setting. They're also trying to follow the empiric treatment based on hospital antibiogram because the ESBL rate is high, but then they're not reviewing that or changing that once the culture sensitivity results are back. So you develop a SMART goal and you say, I'm going to reduce imipenem by 25% over 6 months, right? So it's very specific. This is the goal I'm setting and this is the time period I'm trying to do it. And that's what we mean by setting SMART and specific goals. And then you go make an action plan to go along with it. So which means what steps are you going to take? Who will make it happen? Assign the responsibility. By when do you plan to complete the step? And then how will you know when the step is achieved? What is that measure of success for each step? So again, I just put theoretical examples here. So you will review and refine the unit protocol for ordering the urinalysis and urine culture. You present the plan to the relevant committee for approval. And then you conduct 48-hour antibiotic post-prescription review or timeout of the imipenem prescriptions with a goal of either stopping treatment or doing the shortest duration or switching to another antibiotic. And you measure the number and proportion of patients on imipenem for whom the timeout was completed, the proportion where some action was implemented. And then ongoing, you conduct weekly review of urine culture orders for appropriateness of testing and give feedback to the ordering provider. And there's an accompanying measure to go along with that as well. So that, I think, was the last thing I wanted to share. But in summary, measurement is a critical component of antimicrobial stewardship programs. Select measures guided by the local problems and feasibility. Don't let perfect be the enemy of good. If you can't get all the data in a perfect way, start small, and the periodic PPS is very useful, highly recommended. The measures of prescribing quantity, quality, and patient or program impact are all complementary, but you cannot start doing all of that simultaneously if you're just starting out. So again, start where you can. And use quality improvement frameworks for antimicrobial stewardship implementation, and in that incorporate data and measures into your action planning and implementation. So that's all I have. Thank you. And I did list some references in case you want to look those up as well on how to select metrics and what to measure. And I will stop sharing.
Well, thank you, Surbhi. It was a very enlightening talk, and thank you so much for getting up early hours in the morning to give a live talk. Thank you so much. We will, if you are around, then we will pose the questions if there are any for you, or otherwise we will email them to you. Thank you again.
Thank you.
So let me, we are running a little late in time. So let me quickly introduce Dr. Varun Kapoor, who graduated from Maulana Azad Medical College in 2010. Our next speaker He completed his general surgery residency training program from Case Western University in Ohio in 2018 and has been in clinical practice as a general and trauma surgeon. He's a fellow of the American College of Surgeons and currently pursuing a master's degree in public health, MPH from Johns Hopkins University. And he will start a trauma and surgical critical care fellowship at Duke University in 2022. His area of interest is strengthening health systems and improving quality of surgical care in low and middle income countries. So I think he's very appropriate to talk to all of us today. And most welcome, Dr. Kapoor. We will not delay you because we are already running late, and thank you for getting up such early in the morning to be with us today.
Thank you for having me. Can I share my screen then? Thank you for having me. Can I share my screen?
Yes, sure. Nikita, can you just share the screen with Dr. Kapoor?
This is. Can you see this?
Yes, we can. Thank you.
Okay, so I will start and we'll try to get you back on time. So good day to everybody. Thank you for inviting me to this fantastic conference for the sharing and dissemination of ideas. And I've been attending since the first day, and it's been a really good experience listening to thought leaders from around the world. And then in my own backyard in Baltimore, which was Dr. Leekha, the previous speaker. I have no disclosures. And I hope you will be able to take away the following from my presentation. We'll briefly look at stakeholders who are involved in antibiotic stewardship, discuss the different scenarios where the antibiotic use is present in surgical patients. And then we'll evaluate ASP from a lens of systems thinking, which is my area of focus and research interest. The obvious disclaimer is that my training and experience primarily comes from the US, and my clinical work in remote settings in rural India have helped shape my thoughts that translating ideas to an LMIC must be done carefully, understanding the context and culture, which Dr. Subramaniam earlier today emphasized very nicely with his pictures. So the first were obvious, and the critical care management in the ICU by surgeon is more of a model in the US, which is also my area of future specialization. So I feel the different scenarios require an individualized approach, even if they come under an umbrella. And what works in one scenario might not work the same way in the other. And we will talk about this a little bit in the later. So obviously this has been discussed ad nauseum about restricting antibiotic use. And that's what the focus overall is, not just of this conference, but overall everywhere in the world with ASP. We just have to be mindful also of the fact that people die more throughout the world more with lack of antibiotics than with inappropriate antibiotic use still because of access issues. So I think the obvious question here is who decides the antibiotics for the surgical patients in your hospital? And I think this is a very creative meme by one of the antibiotic stewardship teams on Twitter. And I think it emphasizes two things. One, obviously, it shows you some stakeholders, and in the form of pharmacists and nursing and registrar, and some of them have talked yesterday about their roles and their perspectives. But it also talks about the conflict, I think, that takes place, and this is not uncommon in an early stage scenario when ASP teams are implemented. Conflict and brainstorming is an essential aspect of team growth, and we will talk about it more again a little later. So this is more discussing who the stakeholders are, and these are primarily the bedside stakeholders with direct patient contact. But this stakeholder model does not take into consideration accountability, and the absence of accountability, I feel, is the biggest challenge to the successful implementation of an antibiotic stewardship program. In public health, we discuss accountability as perhaps the most important factor in health systems where governance fails. And this is why I feel antibiotic adherence only at the clinician level is not going to be fully successful. It needs support from beyond the bedside as checks and balances to the system. And this is a scenario that I will try to elucidate in the next slide about how rising costs influences policymakers to impose regulations and on hospitals, and how medical malpractice also influences how hospitals act. And now we're just talking about the ASP at this point, and how hospital provides guidance to the bedside providers about implementation of the ASP. So a scenario from the US is that rising healthcare costs, along with rise of the superbugs, forced former President Obama in 2015 to take notice and pass a law on significant reduction of antibiotic use by 2020. And this led to new guidelines. And I want to now make sure that I have been able to put my point across about this model that we see on rising costs leading to President Obama, leading to passing of new regulations, and how that affects hospitals. So just to highlight how the surgery model works in the US, and not that I have I won't pretend to be an expert in the Indian health system, but it's somewhat a little analogous to the relatively recently introduced government health insurance and the NEBH accreditation. But most surgery patients come under an insurance model, where the hospital gets a fixed amount of money for the surgery and post-op period. And if patient comes back with the surgical site infection, the hospital eats up the cost. So there's more incentive for the hospital to prevent infections, and also not just prevent, but also limit to following the guidelines, so that they can say that, we follow the guidelines and we still had an infection, but also using cheaper antibiotics because it all comes out of the fixed amount of money. So they have an incentive to preserve the profit margin. So now we'll just go over some examples of checklists. And obviously everyone is familiar with the So everyone's familiar with the operating room checklist, and some clinical practice guidelines. I think Dr. Leekha also referred to, and Dr. Subramaniam earlier referred to, and some order sets in the electronic medical records for selection, dosing, and monitoring, and then having pharmacy and nursing as part of the team, so that we have a systems approach. We have we have an extra set of eyes, extra sets someone else is checking, both in the ICU team being separate and on the floors. So this is the surgical checklist. Every hospital in the operating room, and every hospital fine tunes it to their own scenario. And here I've highlighted where the antibiotic prophylaxis is written. And in our checklist, we have fine-tuned it to GI surgery, which has this specific antibiotics, and otherwise these are the alternatives. And if this is weight-based, there's allergies. So we talk about those things, and again, to remind, this is not to limit us, force us to just follow this. We're not mandated right now, but this is more to provide guidance, going over the checklist in the operating room, talking about it, and this is a frequent deterrent to deviation from the routine. This is something that from the Johns Hopkins Hospital. This is the antibiotic guideline that the antibiotic stewardship program came up with quite a while ago, and they have been updating it every day. And again, want to point out to two things. First, on the left side, you see these are the guidelines. Again, these are meant to guide the healthcare providers, not enforcing them. But now, if you look on the right side, we're talking about piperacillin, and there's restriction. Okay, so you need ID approval, and unless they're part of an order set. And again, it's not prohibition. It's restriction. Again, a deterrent, but they're not saying that you cannot use. You just need to seek out ID consult. So now coming to our topic, I've been talking about multi-sectoral problems and the systems, policymakers, but in reality is that we don't have a good way to study beyond the hospitals. We don't have a good satisfactory measure. The most robust evidence that we have at ASP exists at the hospital level. And in surgery, it exists in perioperative prophylaxis, where there's an ample literature that if you're able to ensure compliance, then you can reduce antibiotic utilization and cost, and checklists are a good way. ASP implementation via checklist and EMR is a good way. However, when we try to impose our success from the perioperative field to the treatment field, we are not that successful. And this is from Johns Hopkins again, where the compared what patients, this is retrospective review where they compared what patients got from the providers and compared it to what the guidelines said, and they found the treatment deviation was in 73% of cases. And more often than not, our treatment deviated from the normal of what was recommended. And 25% of patients were treated with too broad a regimen, and 60% were treated beyond the recommended duration. But so the conclusion was surgical practice, even at medical centers with ASPs, fails most of the time. However, there's some key learning points. And one is that this only includes infections, not perioperative prophylaxis, which we have talked about even before. Is that I think we have achieved some measure of success with compliance and antibiotic utilization and costs. However, as you can see through this graph that is coming in from the same paper, most of the issues, as you can see, the organ space infection is where the deviation is most prominent. And post-op, this is more of over caution, more of the fear of the unknown, that we are over treating. It's not that we are not, again, this study shows us that it's not that we are treating the wrong bacteria. It's not that we don't know what is, that metronidazole doesn't work for Staph aureus. We know that, but we are over treating essentially. It's not that we're under treating. So now we have more of an idea where we are failing with this model. So I think this is not comforting in healthcare. You win some, you have success with perioperative prophylaxis, and you don't have the same measure of success with post-op surgical infectious outcome. It doesn't work in healthcare because, our losses are measured in increasing morbidity, rise in deaths, increasing incidence of superbugs, and rising healthcare costs. So, we finally come now to the crux of the topic that been provided, was the challenge of ASP implementation, or this understanding the implementation science in surgery. And what I've learned in my field of public health so far is that you come up with research is one thing, and you implement it in field, in practice, in that particular context is entirely different. So there is a disconnect that we have to appreciate between the ASP, the systems approach, and the surgical providers. And this primarily stems from a lack of surgery leadership involvement in antibiotic stewardship. And they have done studies where they have encouraged providers to join, and when the senior surgery leadership joins the ASP, there is increasing adherence and increased successful uptake of the ASP guidelines. There's not much training or awareness during our residency training, and this is something that we can all relate to. Since this is, even though this has been talked about for a long time, but at the resident and the training level, at the earlier level, when habits form in all our respective fields, very few fields apart from medicine and infectious diseases themselves talk about it that often. Then obviously there is a culture thing in surgery. This has also been studied, unfortunately, that surgeons are noticeably less compliant with antibiotic recommendations. And there's scant literature on implementation science of ASP in surgery. So surgeons are not that attuned to studying ASP and antibiotics and guidelines and systems so far. So throughout the surgery literature, there is literature, but there is less. It's not an area of focus. And you can put the blame on surgeons here for being late. This came out of a paper in India, which is very relatable everywhere, and it's a qualitative assessment from secondary and tertiary hospitals. And the first point is bang on target was lack of CMAs on antibiotic approach, because as in every field, guidelines keep changing. In surgery, with diverticulitis, for example, uncomplicated diverticulitis, we are moving away from antibiotics. When to send C. diff, and what does a C. diff mean? A positive. So it's not something that a surgeon routinely deals with. It's not something that we come across every day in practice, and it's something that we require CMAs, and that's why a conference like this, where all the stakeholders are on board, is a fantastic forum for learning and knowing more about what's going on everywhere. And we talked about absence of champion. And I think there's some things that are was even echoed by some surgeons in the conference earlier a couple of days ago was people they worry the patients will leave practice, they worry about fear of litigation, unreliability of antibiograms, and also the culture in patients being that they have to get antibiotics, and it's a social thing, has to be handled again at something at the systems level, and that cultural social change will take a long time, that the patient might leave you and go doctor shopping if you don't provide antibiotics. So this slide is a little out of sync with the other ones, but I wanted to post this to talk about, referring back to the earlier meme that I showed, about when we implement teams. And here we'll talk about ASP teams. It goes through this transition. It goes through, it's called the 5 stages of norming: forming, storming, norming, performing, and adjourning. So, but the important thing is, during the storming is when we are still resisting control by the group leaders, and we still act as individuals. And this is something that I feel like it is essential for team growth. And this also is a point where teams falter, because this is the point that they stop working. But it's important to forge through this, reach a common ground, and come to a common consensus with an common overarching goal for the success of team. And here we're talking about the team when an ASP team forms in a hospital. So what are the solutions? Here it's, we talked about ASP being a superior approach, but we are surprisingly disappointing results at implementation. But there are no easy solutions to this complex problem of implementation science. And it's primarily because of multiple stakeholders across multiple sectors that make it difficult to solve. And this is, again, the benefit of conferences like these, that everyone can come together, talk about this, and again, maybe talk more about what's the right approach. So I think Dr. Leekha emphasized this with an excellent example of SMART goals and surgical patients at our hospital where they studied the imipenem. But we have to focus on the right points now. We have learned what we have had success with. We have to keep doing what we are doing, but in fields where we have not had success, we have to identify the factors. And studies like the one that I showed earlier have helped, in changing our approach. So, we go qualitative study, we realize there's no CMEs, we do CMEs, we introduce this, make it a part of training education, we engage senior surgeons, and, you approach this in a stepwise fashion and keep, you monitor, evaluate, get feedback, study your microbiota at your hospitals, see, okay, the guidelines are not with what's followed in the Western world or in the European literature. And as Dr. Subramaniam said, you have to look at context. So, in that regard, we are going forward with the study at Medanta in December, where we'll be studying these studying microbiota in WIPO patients, and hopefully, that can provide some guidance with the ASP for antibiotic revision if it is needed. So I want to end this with a couple of personal stories. Vancomycin nephrotoxicity that I encountered in a month rotation at an outside hospital during my residency training, which was not that long ago. And we found 6 patients in 1 month in the hospital with vanc nephrotoxicity, one of them requiring dialysis, where we were consulted. All of them were on different services, and it's easier to put blame on each other, but it was easier yet to come up with a solution. And that solution, was being implemented at other hospitals before and since, but it was just introducing 2 things into the vanc order set. One was adding the vanc prop that we get before the 4th dose, adding it at the time of when we order the 1st dose, so that doesn't get missed. And 2 was adding vancomycin dosing by pharmacy. So they will follow along another set of eyes, another way to prevent human errors that we keep encountering. And the other was during my clinical practice, we got an email from the hospital leadership saying that, from the ASP, saying that, the guidelines are changing for ASP implementation for colorectal patients. And these are the antibiotics you'll use. These are the alternatives. We'll be monitoring the order sets, and let us know if you have any questions. And you might feel powerless that you're not making the decisions. But I was reassured in our case because the email was sent by my colorectal chief, who is also was involved in the leadership at ASP. So it was reassuring. A surgeon in clinical practice who sees patients, he's representing us, so he understands, if you're changing antibiotics and what our needs are. So getting surgery leadership involved in making in ASP teams is a big factor in ensuring compliance with the rest of the hospital system. So I'll end with this. This was from Dr. Paul Anand on our first day at conference. This is how the first day closed, that we need to give the ASP some time, even the surgeons will get hooked on. And surgeons are notoriously late joining the party. So, thank you. I will be happy to take any questions.
Thank you, Dr. Kapoor. I think it's very important to get the surgeon's perspective, which we just got from you. And we will have questions after the sessions, finish. So because we are running late, I will quickly go on to the next speaker. Our next speaker will be talking about how to create institutional guidelines. Dr. Kamini Walia from ICMR, that is Indian Council of Medical Research. She's a clinical microbiologist and has trained in public health from Johns Hopkins University. She's working as a senior scientist in the Division of Epidemiology and Communicable Diseases, Division of Indian Council of Medical Research. The most important thing about Kamini is that she's, for the last 20 years, she's been working in AMR, antimicrobial resistance. She herself has faced many resistance, but she has pursued her goal. And I must say, she has done a wonderful job of creating guidelines, national guidelines, with the help of a good team. Dr. Ram Subramaniam is a part of her team, and I would now request Kamini to share her presentation with us.
Thanks. Thank you, Dr. Sharmila, for a very kind introduction. And can I share my screen now? Okay. Fine. And I really am grateful for this opportunity to share this experience of creating the national guidelines, as I am the program officer for Antimicrobial Resistance Initiative at the Indian Council of Medical Research, and have been part of various I have coordinated creation of various guidelines under this particular initiative. So grateful for this opportunity to share my experience. Now, Indian Council of Medical Research, as many of you would know, is a key organization for funding medical research in India, and antimicrobial resistance has been one of the important areas, and ICMR has invested consistently towards improving our understanding of antimicrobial resistance in India by funding different initiatives. And one of the key objective has been for generating the reliable evidence so that the policymakers have the data, necessary data to create policies and take decisions with respect to the AMR containment. The other areas that we have been able to initiate is strengthening the diagnostic stewardship, the antibiotic stewardship, infection prevention and control through different programs that are being funded by ICMR. We also support the research and development so that we understand the mechanisms of resistance, transmission dynamics, basically also trying to follow the One Health approach as we support the basic and the clinical research. Now, this is what the ICMR initiative looks like. We started AMR surveillance in 2013. we publish the yearly trends and the patterns of AMR from India, which is available on the ICMR website. Then there is a full program addressing the infection prevention and control, the HAI surveillance, and basically aimed at building capacity for infection control in hospitals and create interventions that are suitable for developing country settings. And in 2018, actually, we started this one of the kinds program for establishing the structure and process of antimicrobial stewardship in different hospitals in India, because as most of you would know, most of the hospitals in India don't even have an ID physician or a clinical pharmacist. So practically the structure and framework of implementing AMSP doesn't exist in Indian hospitals. So it was a very challenging task to initiate, because this particular intervention, it requires complete cooperation of clinicians. And unless we have that commitment from the clinicians, this program cannot take off. So since we have undertaken, we started most of these things from scratch. For example, surveillance. Although a lot of labs were generating antimicrobial resistance data, but they were using different guidelines. And in absence of a common national guideline, which the labs use, it is very difficult to collate or collect that data and draw some meaningful inference out of it, so that we are able to get some nationally representative picture. So when we started establishing the surveillance network, one of the most important requirement was an SOP, a common SOP which all labs could follow. That's how the requirement for guidelines came in, and we released multiple guidelines over next few years. First among them were the SOPs for the laboratories, which is the bacteriology and mycology SOP, so that we give something to microbiologists which help us in creating standardization and harmonization in the processes which are used for collecting data, so that the data is also as per the international guidelines, and it is seen as something reliable which is coming from India. Next was the infection control guideline, in which we provided guidance to the hospitals how they can set up an infection control program in their hospital, depending upon whether it's a tertiary care hospital, secondary care hospital, or it's a small nursing home or a district hospital. Then we also released the first treatment guideline for common syndromes, for use of antimicrobials in common syndromes, and that was released in 2017. We made the data available to the committee that was constituted, although there wasn't much data available at that time, but we released 2017 treatment guideline, because there was a lot of demand as to as the doctors did not know how to use antimicrobials, and most of the time there is no knowledge which is given on antimicrobial use once the doctors have completed their respective academic degrees. Next came the Antimicrobial Stewardship Guideline. Also realizing that the number of Candida auris outbreaks were increasing in our country, we constituted a group under the leadership of Dr. Arnalok Chakravarti, who is a well-known mycologist from India, and we released the guideline on how to control Candida auris outbreaks in the healthcare settings. But no guidelines are static. So as more evidence becomes available, as more data becomes available, we have to also update the guidelines. So in pursuance of that, we released the updated standard operating procedures for bacteriology and mycology for labs, which were as per the CLSI guidelines. And we also released the second edition of treatment guidelines, as we had more data, more reliable data available to us. So we thought it is timely that we revise the treatment guidelines now that we have data from Indian patients. So this has been the journey of creating guidelines in ICMR, and there are few more which will be coming out in next year, which will be more focused and more specific. And quickly now, for next few slides, I will take you through the process that is generally recommended. What are the pitfalls as to why sometimes when the guidelines, even if they are present, they cannot cannot be adapted and they cannot be implemented, and how did we do it at ICMR? I hope you find this interesting. So why are guidelines becoming so important? Last two speakers referred to the importance of guidelines and why it is so important that we should have guidelines so that there is a document that doctors can refer to. Lately, there is increasing popularity, particularly for antibiotic usage guidelines. BSAC, in one of the surveys, reported that over a period of couple of years, they have the respondents confirmed the availability of antimicrobial use guidelines. It increased from 62% to 70%. In an ICMR survey that we conducted in 2017, the comprehensive guidelines were missing in most hospitals, although they had some syndrome-specific guidelines which were available. But as of 2021, all the hospitals which are part of ICMR network, which are about 20 odd hospitals, they all have an antibiogram-based antibiotic policy guideline. Now, why do hospitals and doctors prefer to have guidelines? Now, what are clinical guidelines? It is basically a systematically developed statement which is useful for practitioners, and it helps them guide on patient decisions about appropriateness for specific of antimicrobial use in specific circumstances. It actually serves as an educational tool which promotes evidence-based decision-making. It is regarded as a useful synthesis of evidence or consensus, and which is coming from a group of responsible and informed practitioners. It should reduce variations across the methods and the standard of care, improve the appropriateness of quality, cost, and cost effectiveness of care. And in this particular case, for antimicrobial resistance, I think we really want to see reduction in the levels of multi-resistant organisms. Now, there are different stages of guideline process. Basically, whenever we are trying to introduce a guideline, we are trying to introduce a change. We want the practice to change. And the hope is that something will change once we introduce the guideline. But that will actually depend on what is the process which is used for development, how do you disseminate it, and what mechanism do you offer for the implementation. So the most important here is that we avoid duplication. Is there a document which is already available in the hospital? Can you improve the existing document by providing additional evidence or additional data? If not, then only go for a completely new guideline. Create a multidisciplinary group, and the guideline must be based on a systematic review of scientific evidence. I will come to the downside of absence of scientific evidence in my later slides. In absence of robust evidence, most guidelines will be based on the hybrid of varying degree of evidence as well as an expert opinion. So it is very important that we choose the clinical experts very carefully. Then we have to keep it short and simple. We cannot have excessively long documents, and documents should be of a small to moderate kind of length so that they can be easily referred to. They should have been reviewed by respected peers who are experts but not part of the guideline panel. And the guidelines should also offer identify evidence that is lacking and identify areas for further research. Then it is important to identify sample outcome measures that would form the basis for auditing for both the process as well as the outcome indicators of the guidelines. Now, the problems and limitations in guideline development is that in most of the low middle income countries, there's lack of scientific evidence to support many of the recommendations that comprise the guideline. So what do you do when you don't have the data? Besides that, the cost of developing and implementing guideline can be considerable. And who bears this cost of developing a guideline? In our case, ICMR was bearing the cost of engaging experts, organizing the meetings. But in most, at the institutional level, sometimes resources can be a constraint. And moreover, I think now we are meeting more virtually. So we are all used to Zoom calls. But earlier, all these consultations and meetings were happening in person. And that requires your experts to be flying in, organizing the actual meetings in a particular venue. And all that takes resources. Besides that, I think there has been very little guidance on methodology of guideline development. I honestly learned as I went forward. I could not refer to any document as to how I should be coordinating the guideline development process. Then the other most important component of towards implementation of guideline is the step on dissemination. How do you make guidelines available? What do you do to really circulate that piece of knowledge that you have created so that there is acceptance of that document? The process of bringing guideline to attention and their intended users for increasing awareness, influencing the knowledge, attitude, and the behavior is what comprises the dissemination. The optimal method is not known as yet. Educational methods for dissemination are better adopted. And also, it is important that a guideline is also linked to effective implementation strategy. If you don't have an implementation strategy, it is not possible to create that traction for the document for which there is no system to implement it. Now the things have changed. Most institutions have IT systems, and then there is a social media platform which can be utilized to circulate the documents. Now, coming to the most important part of the guideline, which is the implementation. Just creating a guideline by itself is not an important feat. We really want it to be implemented, making sure that the purpose for which it is intended and it is introduced into the clinical practice. So it is very important that we promote the ownership of guidelines with the stakeholders or with the audience that we want to use these guidelines. So there are different ways to do that. First is involvement of potential owners in the development process. And then is the educational interventions, like opportunity to discuss guidelines is more effective than didactic lectures. Endorsement by the local or national professional organizations, it goes a long way in creating acceptance for the guideline and incorporation it into the routine practice. Opinion leaders, departmental heads, and a process of audit of compliance and providing the feedback to clinicians, again, are very important steps and go a long way in creating acceptance for the guideline. The implementation the problems with the implementation of the guideline in most situations is that we have the guideline, but we don't have the system to support that implementation. We are also guidelines may not be sufficiently specific to the clinical situations. They may not address the comorbid and the concurrent therapy situations. They also sometimes fail to account for patient preferences. There is no agreement on the optimal methods of implementing guidelines, but availability of a system and resources to implement the guidelines, I think, is one of the key component that will determine whether the guidelines are accepted or not. I will just give a brief example of how we introduced the importance for treatment guidelines and the AMSP guideline. The treatment guideline, which ICMR released in 2019, has actually been downloaded 2,000 times, when I saw it recently. So that means the document is fairly popular and being utilized. We did a survey of 20 hospitals across the country, and we wanted to look at what kind of AMSP processes and structures exist in the Indian hospitals. 13 public and 7 private hospitals participated in it. And we realized that AMSP document was only available in 4 out of the 20 hospitals. The infection control document was available in most hospitals. The hospitals did not have ID physicians and clinical pharmacists. And most important was that there was no comprehensive treatment guideline in most hospitals, although syndrome-specific guidelines were frequently available. AMSP was not linked to IT system in most hospitals, which you can understand is a challenge for circulation and dissemination for any material related to antimicrobial stewardship if you don't have an effective IT system. Similarly, challenge was to provide the prescription audit and feedback, which was being practiced only by 2 out of the 20 hospitals. So taking cue from these findings, ICMR did a focused strategy on creating capacities for antimicrobial stewardship in these hospitals who participated in our survey, along with the other hospitals who were part of ICMR, AMR network and other hospitals. And we have trained more than 300 staff in almost 60 medical colleges and hospitals, both government and private till now. Now, the important part was that these workshops were led by ID physician, none other than Dr. Ram Subramaniam, who spoke earlier in this session. And not just we released the antimicrobial stewardship guidelines following this, and following the understanding from these group discussion as to what kind of guidance would be appreciated if ICMR came up with one. So this was followed by a 2-year project, which we did with all these hospitals, in which we tried to build the structure and framework for implementation of AMSP. And you can see that after the implementation of this project, almost all the hospitals had an AMSP document. They had AMSP committees. Their teams, AMSP teams were meeting more frequently. There was anti-biograms which were developed by all the hospitals over here. And also the antibiotic policy was almost available in all the hospitals. So this is the other thing which I want to mention here is that since we provided them the opportunity to develop the AMSP structure and process. So once they developed the guideline, they had an implementation strategy as well. So that's why it is very important to support any guideline or document with an implementation strategy as to how you are going to monitor your progress and what indicators you are going to use. So briefly, the process that we followed at ICMR was first to identify champions in the field. Our AMSP program was led by Dr. Ram Subramaniam, and our the treatment guideline group was led by Dr. Ram Gopal Krishnan both from Apollo hospitals. And I can't thank both of them enough for their such meaningful contributions to the ICMR initiative. In fact, the whatever success we have seen is because of the leadership provided by both of them. Other than that, we had many able ID physicians and clinical microbiologists who helped us put together multiple groups which were led by their clinicians or ID physicians or intensivists. And that's one of the reasons that we wanted the clinicians, ID physicians and intensivists to be the face of AMR and antimicrobial stewardship, so that because that creates more buy-in and more effective implementation strategy for other clinicians as well. Then providing evidence was something that ICMR surveillance network did very effectively. We ordered all the experts who spared time for this activities compensation for their time. We created national documents with necessary caution that they must be customized and adapted locally, because the ICMR's network data, surveillance network data, it comes from the tertiary care hospitals. It has a bias in the sense that the most of the hospitals have very high level of resistance. So if somebody goes by the ICMR national level data, they will only be prescribing very high-end antibiotics. So all the hospitals were trained to create their own antibiograms as well as create their own antibiotic policy, which they will follow. We have undertaken periodic revision of the guidelines that we have released when more data becomes available. And we definitely acknowledge the contributions of all those who have contributed very generously to this initiative. So to summarize, guidelines are not static. They are dynamic documents and they should be kept like that. They need to be reviewed and updated at periodic intervals. Whatever new medical knowledge or changes in the clinical practice or local circumstances, whatever new knowledge becomes available, they should be added to update the document regularly. Any modification in the guideline must be a result of the rigor and the commitment as the original recommendations. So the challenges in maintaining the rigor and commitment is that we need to sustain the quality of the guidelines. We need to remain relevant and maintain the focus. Wherever there is a duplication happening, don't indulge in that. only invest your energy and resources into creating something that doesn't already exist. And one really needs a lot of patience to handle these multidisciplinary teams, because we are working with very busy clinicians most of the time. I mean, they are very generous with their time, but sometimes we have to be very patient with them as well. Timely review by the experts. This is one thing, again, which is very challenging, getting the feedback on time and keeping your timelines. Then managing expectations and practical challenges as we move forward. Thank you.
Thank you, Kamini. It was very enlightening, and we really appreciate the work you have done and you are doing. So thank you again. We are running a little short of time, but I have our moderator, Dr. Yatin Mehta, who will take the questions with the speakers. Thank you.
Yeah, thank you, Sharmila, for sitting in for me. I have been in between attending listening to the lectures, and I have heard the lectures, the pre-recorded ones beforehand. Thank you, Dr. Walia. It's a pleasure to hear you, and I think excellent effort. See, I mean, this last 2.5 hours, we have covered the full spectrum of how to start the process of antibiotic stewardship program. In some of the speakers from the Western world, some from India, and we know that there are difficulties everywhere. More so in the Indian context. Dr. Varun Kapoor is a surgeon. He'll vouch for me that how feudal some of the surgeons can be. And once they say that the whole standard, this thing is, I've been using this for years. All my life I've used this antibiotic. Who's this young ID person telling me what to do? So that is the problem. I think in India we have huge antimicrobial resistance problem, not only in the hospitals but also in the community. We are seeing MRSA coming from the community. We are seeing ESBL, the water in the sewage and in the drinking water. So I think this problem is huge. We have a little different spectrum of antimicrobial resistance and the bugs. MRSA is a serious problem in the Western world. We are not so much, but it is increasing over the last, if you look at the data over the last 10 years or so, it is increasing in hospitals. And gram-negative sepsis remains there, particularly the carbapenem-resistant organisms is a serious problem. So I think it has taken me at Medanta 10 years to implement the antimicrobial stewardship program. And now we sit down with all the teams and we review the antibiograms over the last 1 or 2 years, and then we review all, and then we publish the what antibiotics should be used in with what illness, syndrome-specific antibiotics or bug-specific antibiotics, whatever. But it has been an upward difficult journey, and if in a tertiary care hospital if it is like this, I can imagine what it would be like in the major big government hospitals where the professor is God. So I would open the questions to everybody who would answer. I think Dr. Leekha talked about outcome auditing. So my question would be how frequently, in practical terms, you can audit antimicrobial stewardship program as well as antibiotic prescription patterns. Is she there?
I think she's not there because it's an odd time in US. But I think Dr. Kapoor can take this question, or anybody else who's there. Maybe Kamini also.
Yes, I think auditing is a process that's actually ingrained in the systems in US. I can vouch for looking at you. I do the surgery that it is not beyond my expertise, and it could be that later on I might hear. And if I have a major application, so auditing and reviewing literature is easier in the US system just because they've been doing it. It's very tightly regulated to the point sometimes people feel suffocated on the other side. However, in terms of, I think, guideline implementation, it's easier. I think because it needs a lot of resources. However, I think with the more of the digitization that we see now with EMR. So now, if you go in the EMR, I think it will not be difficult to come up with a program like here that how many people are coming up, are following the guidelines. Right now, we need resources, we need people doing it. But if you can train the EMR and take it out of the hand, and you'll find out, the EMR will automatically give you a push that, Dr. Kapoor, it's been 5 days you've been using this antibiotic. Give us a reason that you still want to continue.
See, as Kamini rightly pointed it out, many of the hospitals don't even have an ID guy. Whole of India, Rama Subramaniam has said, the whole of India has about 100 plus ID guys. So that is the problem. I mean, who's now going to tell the clinician that your antibiotic therapy is inappropriate?
Sir, we gave
Yes, Dr.
clinical pharmacists. We funded position of clinical pharmacists in most hospitals. It was not possible for us to fund positions for ID physicians. So we trained clinicians or intensivists on ID. Those trainings were done by Dr. Ram Subramaniam, and that's how we identified PIs also for AMSP in these hospitals. These are basically people who are passionate about AMSP, who understand the perils of antimicrobial resistance, whether they are intensivists or other internal medicine guys. And the other thing is clinical pharmacists. So when we give clinical pharmacists, in our experience, we were implementing AMSP in the limited number of beds. We were not spread out. This ICMR project was not spread out over the entire hospital. But the net result was that 2 hospitals, Hinduja Hospital and Gangaram Hospital, they have now created a permanent position for clinical pharmacist in their hospital, so that the clinical pharmacist is able to regularly monitor the dosages and the prescription patterns. So this is the net result that has happened in these 2 hospitals. Now I know the first reaction would be these are private hospitals. They can change their system. But then what do you do about government hospitals? I think this change is going to come about slowly. Now that National Medical Commission has made it mandatory that ID physicians should be there, they have come up with the guideline for antimicrobial stewardship now. So, I mean, when they implement AMSP, they will have to provide human resources. And AMSP cannot be implemented without human resources. Only if you provide trained human resource, that any kind of auditing or any kind of feedback will be possible.
No, I think that's the way to go, because a clinical pharmacologist or pharmacist does not cost much.
Yes.
So we have hired 20 clinical pharmacists. In every acute area, we have one young clinical pharmacist and who audits, and he tells whoever is involved, the chief clinician there, that this is not right or whatever.
And the support has to come from the leadership. So once the leadership is sensitized to this whole thing, that they have to provide the logistics and resources, then the change will come by.
And for, again, important question, for restricted antibiotics.
Yes.
Should it be stopped?
No.
What do you think?
So we had given 2 options to the hospitals: introduce formulary restriction or prescription audit and feedback. And for formulary restriction, we did not give them any list that this you have to implement. This is their own choice. So some hospitals have implemented formulary restriction with 1 or 2 or maybe sometimes 3 antibiotics, and they have decided who is the authorized person to sign off those prescriptions. But other than that, not many. They all found prescription audit and feedback to be a better way for implementing AMSP rather than restriction.
Yeah, so what we do is that I permit three doses, because
Okay.
and then after that, restricted antibiotics or antifungals have to be, validated by the
Right.
chief of that department.
Yeah.
So if he does it, then it's well and good. If he doesn't do it, then obviously it will be escalated to him that why, it's not been done, and is there really an indication of continuing or not de-escalating?
Right.
That's
I think one thing that we have been able to do from ICMR is at least put that ignition on, So that is taking it forward. Now, hospitals are doing very well. In fact, we recently had a meeting with Dr. Ram Subramaniam chairing the meeting, and he said the hospitals have fared better than what I expected. And there are more government hospitals and ICMR network. Of course, there are corporate hospitals as well.
And that comment coming from Rama is a big thing.
Yes.
They are very conservative. He's very conservative in
I know.
Can I just say a couple of words?
Yeah, sure.
Okay.
Yeah, no.
Good
One thing
evening.
is I have to place on record the passion Dr. Kamini Walia has shown in this intervention. You know, she's been the driving force of this, and we all know that things can't happen overnight. I look at it as even if in one day, by means of an intervention, we cut down 10 prescriptions of an antibiotic, that is progress. So it is very difficult. We are looking at perfect results, looking at the West and comparing ourselves. It's not possible. You have to take one step at a time. I think we have taken at least 3 steps so far. How we make sure that this is accepted by everybody and made a self-sustaining, intervention is what we should focus on from now. I think the NABH is doing an excellent job. And I think it's going to change. The time is not yet right, but it's started. I think only when the curriculum changes, I think we can expect more. So I'm very confident.
No, I'm glad. This is the best example of PPP for a constructive purpose. And I think ICMR is also now taking the lead. With COVID, particularly ICMR has come into the limelight and acceptance by the public, and everybody knows what is ICMR. So I think it's a good thing to take it forward. I think Dr. Walia, you must continue this activity, and we always there to support you.
Thanks for your support.
So I think now it is getting late in the evening, even in India. So I would like to thank all the speakers. I would like to thank my co-host, Dr. Sharmila Sengupta, for sitting in for me. And I think it is next day's program is going to be 2 days is very good, and this 3 days program will start the ball rolling, people at least thinking that what needs to be done to control the antimicrobial resistance and unnecessary use of inappropriate antibiotics, particularly in this part of the world. So thank you very much, all of you, for that.
Thank you, sir. It's pretty late out here, but I must say that I'm really enjoying, the presentations and talks, and we look forward to the next 2 days. And I hope the participants from Philippines, Bangladesh, Nepal are also enjoying the program. Thank you.